Good morning, colleagues. I hope you are all well. We are starting the program for today. My name is Jacob Nsolensegale. I'm the M&E manager for SADC PF. I want to welcome all of you to these 2 days on regional budget analysis. But before I start, I just wanted to remind everyone about the pre-assessment that needs to be done before we start with these particular sessions. I will be talking about countries that are still outstanding in terms of the pre-assessment. Lesotho, there's still 1 person missing. Mauritius, there's still 1 person missing. Zambia as well as Zimbabwe is still one person missing. And then Swaziland, all the 3 participants haven't completed their pre-assessment surveys. Namibia as well, 3 people have not completed their survey. And then I don't know if there is Tanzania as well. They haven't completed. Mozambique, we need 1 person. Angola is 3. I know Angola is not joining us. DRC also is 3. So please, if you have time now, I will suggest that as we continue to introduce ourselves, we log into Google Forms. The links were provided. If you are using French, please look at the link for French. Those who are using Portuguese, look for the Portuguese link. Those who are using English, look for the English link. Colleagues who are SADC PF researchers, please share with your colleagues from your parliaments the links so that they can be able to respond to the survey. Thank you very much. Let me also take this time to just acquaint you with the setup. As you go out the door, there will be tea facilities that will be served there. And then there will also be restrooms that one can use, both male and female, they are outside. And then in terms of the languages for interpretation, I think English is 1, and then Portuguese is 3, and then French is 2. So please, if you are talking as well, ensure that you first press the mics so that you can be able to talk, and then after that you can turn it off so that we can be able to communicate effectively. These sessions will be a more practical session. So there will be a time where countries will be breaking down to groups so that they can dwell into their country and then look into their country-specific budget analysis in the next 2 days. Now, without wasting any time, I would like probably for colleagues to introduce themselves. Maybe if we can start from, let's go alphabetically. Let's start from this side. We will start with countries first, and then from there we will move to the resource persons, and then we'll move to the secretariat, and then from the secretariat, then I will then lastly introduce our Secretary General. Thank you. Can we start with Botswana?
Good morning. My name is Mosarwa Segwabe with the Botswana team as the SRHR researcher.
Good morning. I am Onkgopotse Metlaleng from Botswana, the finance officer in Parliament.
Good morning. My name is Rosa Mokone. I'm the Performance Improvement Coordinator for Botswana Parliament.
Good morning, Madam SG. Good morning, colleagues. My name is Zanele Kwabe. I am an SRHR researcher from Eswatini.
Good morning. My name is Nikiwe Mapalala. I'm the financial controller in the Parliament of Eswatini. Thank you.
Good morning. My name is Pindile Slongonyane. I'm in the HR department in the Parliament of Eswatini.
Good morning, everyone. My name is Mamehela Matamani from the Parliament of Lesotho. I'm the SRHR researcher. Thank you.
Dumelang, good morning. My name is Alere Kumaine, Director, Parliamentary Budget Office, Parliament of Lesotho.
Good morning. I am Sito Ledimo from the coldest country in the region. I work in the parliament as a chief research officer.
Bonjour, Madame SG. Earphone, please. I will speak in French. Bonjour, Madame SG. Bonjour, collègues. Moi, c'est Ida Ravilson. Je suis la chercheuse en SDSR à Madagascar, au Parlement de Madagascar. Merci.
Bonjour à tous. Donc, moi, je suis Naoudrik Tafita Siedien de Madagascar, de l'Assemblée nationale. Je suis en charge de la législation au sein de l'Assemblée nationale. Merci.
Bonjour Madame Essé. Bonjour tous. Je suis le directeur financier de l'Assemblée nationale, Monsieur Ramar Label.
Good morning. My name is Gomez Yaningwila. I'm the sexual reproductive health rights researcher from Parliament of Malawi. Thank you.
Good morning, Madam SG. I'm Sangani Piri, Chief Budget Analyst from the Parliamentary Budget Office of Malawi. Thank you.
Good morning. My name is Annie Kanyangalazi. I'm a Parliament Research Officer for the Parliament of Malawi.
Good morning. I am Mr. Bisesor, Finance Manager, Parliament of Mauritius.
Good morning, Madam SG. Good morning, colleagues. I'm Purnika Amjatan from the Parliament of Mauritius, the SRHR researcher. Thank you.
Good morning. I'm Staram Girish from the Mauritius National Assembly, providing support to the clerk's office.
Bom dia, sou Inocência Tembi, venho do Parlamento de Moçambique, trabalho no Departamento Financeiro.
Bom dia, Excelentíssima Secretária-Geral. Bom dia, colegas. Chamo-me Guida Armando, pesquisadora no Parlamento moçambicano.
Bom dia, eu me chamo Júlio Mário da Costa, sou pesquisador no Parlamento moçambicano.
Good morning. My name is Josephina Shatumbu. I'm a finance officer from Directorate of Finance, Parliament of Namibia.
Good morning. My name is Bridget Fikunawa, and I'm a researcher at the Parliament of Namibia.
Good morning, SG. Good morning, everyone. My name is Cynthia Mutame, SRHR researcher, Parliament of Namibia.
Good morning, everyone. My name is Hannah Wolpe, and I'm the SRHR Research and Project Officer from South Africa.
Good morning, everybody. My name is Busi Sibeko, and I'm the Acting Deputy Director of the Parliamentary Budget Office.
Good morning, colleagues. My name is Berenice Paulse. I am the Senior Researcher responsible for the cluster of Social Services and Infrastructure Committees in Parliament.
Good morning, colleagues. My name is Philip Mwenga from the National Assembly of Zambia. I'm coming from the Parliamentary Budget Office, Budget Analyst.
Good morning, Madam Secretary General. Good morning, colleagues. My name is Aifoma Mulewa. I'm an SRHR researcher in the Parliament of Zambia. Thank you.
Good morning, Madam Secretary General. Good morning, colleagues. My name is Evans Chilongu from the Zambian Parliament, an alternate desk officer for set here.
Thank you very much. Can we have our resource person introduce themselves And then from there, we'll
Sorry.
go to SADC PF colleagues. Oh, there is, apologies, there is Zimbabwe at the back.
Thank you. My name is Tepo Chiremba. I work for Parliament of Zimbabwe as a committee clerk. I'm also a researcher to the project.
Good morning. My name is Lucia Nyao. I am the assistant clerk responsible for committees and SRHR project. Thank you.
Good morning, everyone. My name is Beta Sibanda. I'm a deputy director in the Parliament Budget Office of Zimbabwe.
Okay, thank you, everyone. I think I've covered everyone. Can we kindly go to our resource persons?
Good morning, everyone. My name is Mtambo Simon. I'm one of the resource persons. Thank you.
Good morning, everyone. My name is Asha Jenje. I will be a resource person as well. Thank you.
Good morning, SG. Morning, everyone. My name is Ndamuka Marimu. I'm with the Parliament of Zimbabwe. I'll be a resource person. Thank you.
Thank you. Can we start with the SADC PF colleagues with Raja Debek?
Good morning, everyone. My name is Raj Kubla. I am the project accountant of SRHR project and also accountant for the SADC Parliamentary Forum. Thank you.
Good morning, everyone. My name is Toivo Mwala. I'm the assistant finance officer. Thank you.
Good morning, everyone. Matuga Banji. Ndine Samuel Bogosi. My name is Samuel Bogosi. I'm the internal auditor for the SRHR project as well as the forum. Thank you.
Morning, everyone. My name is Moses Magadza. I'm the Media and Communications Manager at the SADC Parliamentary Forum.
Good morning, everyone. My name is Agnes Lilongwe, Executive Secretary to the Secretary General. Thank you.
Bonjour à tous. Je m'appelle Munache Tofa. Je travaille au SADC PF as Program Manager. Thank you.
Good morning. My name is Ronald Venva. I'm the ICT officer for the SADC Parliamentary Forum. Welcome.
Thank you very much, colleagues. Let me take this opportunity to call upon Her Excellency Boemo Sekoma, the Secretary General of SADC PF, to introduce herself and then also give opening remarks. Thank you. Madam SG. Okay, it's fine. It's fine with me.
Bon dia. Bonjour. Did you sleep really? You sound frozen. Good morning. Oh, that means that it's an issue of who is around. Happy to see you all. Glad that the room is full and that I believe you have all had a good rest. We want to apologize for the logistical nightmare or experience that you had. To go to 2 hotels and, for one meeting. Unfortunately, this is what it is in busy capitals like this one. But I hope that we'll settle in today and that we'll get over that experience and share lessons beyond today. You are diverse. Let me just say, I welcome you all as technical people and staff in your respective hierarchies from your respective countries and want to stand on that protocol as something that would make all of you feel valued. There are those who are familiar to the SADC Parliamentary Forum and those who are not familiar to the SADC Parliamentary Forum. Kindly take this opportunity to learn about the SADC Parliamentary Forum. And I believe that down the line, when the program allows, we will make sure that we give you, as we go along, a brief on the SADC Parliamentary Forum for those who are, beginners to this institution. I'd like to start, colleagues, with an announcement. Just to say it's with profound sorrow and deep regret that we announce the passing of Dr. Jabulile Sisana Malaza on the 11th of April, 2026. She was the Director of Research in the Parliament of the Kingdom of Eswatini. Dr. Malaza was a distinguished former staff of the SADC Parliamentary Forum Secretariat under the Africa Capacity Building Foundation project, and a long-standing desk officer who made a significant contribution to parliamentary capacity building, regional cooperation, and democratic governance. She also served with distinction as a researcher for the SADC-PF SRHR HIV/AIDS and Governance Project in Eswatini. On behalf of the SADC Parliamentary Forum, and on behalf of the researchers who work closely with Jabu, we extend our heartfelt condolences to the Parliament of the Kingdom of Eswatini, as well as to the families and friends of Dr. Malaza, and to all those whose lives she has touched. May her soul rest in eternal peace. I invite you, colleagues, that you rise for a moment of silence in honor of Dr. Jabulile Malaza. May her soul rest in eternal peace. You may be seated. Yeah. Colleagues, I've already welcomed you to South Africa, and I can only hope that you've had a safe trip. I'd like to just delve directly into why we're here today. It is not a workshop where you are going to be taught anything. To the contrary, we are going to hear from you, and you are going to teach us about your respective environments or ecosystem within which the budget responds positively to development issues. In this particular moment, we are interested in the realm of health, SRHR governance, HIV/AIDS, among others, as per the agreement that your parliaments have signed with the SADC Parliamentary Forum, and the SADC Parliamentary Forum has signed with the government of Sweden. First, we're going to explore the results of the budget analysis in the domain of SRHR in your respective countries in the last or in the past 3 years. Secondly, we shall also be planning ahead as the SRHR project draws to an end. Of course, with a possible costed extension to be approved in a different modality by Sweden. Dear colleagues, as you are aware, voting the yearly budgets of the state is a key function of Parliament. It is through the budget exercise that the sexual reproductive health rights is effectively advanced. We believe that sexual reproductive health and rights consists of funding-dependent services, which states need to ensure the availability and affordability by their own citizens. We must remember that nothing can happen without a budget. Even when SRHR law is adopted, for instance, a law on gender-based violence, there are resources that are necessary from the budget for the law to be operationalized. And we believe that this sensitization has permeated through your analysis in your respective countries over time. In some cases, specialized personnel must be, secured, must be recruited, must form part of our parliaments. We know that gender-based violence shelters must be built, or even more, legal aid must be disbursed for victims. The budget exercise must not be underestimated, as it has deep linkages with all other parliamentary functions, including the legislation, domestication, oversight, representation of communities, among others. It is for this reason that this project is interested in analyzing and looking into the funding by states through the budget as a precondition for sexual reproductive health and rights to actualize and to thrive. This is all the more important now that we have a model on public financial management, which also makes prescriptions about the budget process, the Sustainable Development Goals, and international commitments. Those who don't have it, kindly look for it. It will be instrumental as you do your presentations. The least we can do from our end is to propagate the provisions of the model law and ensure that as we report internally on the budget, for purposes of the SRHR project, we also consider the prescriptions and the inherent relevance, among others, of the Sustainable Development Goals. Colleagues, in this respect, we shall examine the results presented per country, and these results shall be included in the end-of-year report to Sweden, with a view to demonstrating the milestones achieved under the project. We also look forward to you examining and demonstrating the cross-sectional linkages between sexual reproductive health and rights, governance, HIV/AIDS, budget and legislation oversight, and representation in this regard. It is not just about numbers. As far as possible, so that the net effect of how our parliaments have mainstreamed sexual reproductive health and rights can be assessed and communicated. You are expected to contribute during the focus group discussions, which will occur during the 2 days, and to present the results in a way which can be conveniently reported through the monitoring and evaluation framework of your countries and the project. Each session in the program has a different purpose and is intended to encourage you to consider the budget from a different lens. You are expected to read and address each session in the intended way in view of optimizing the results, especially as you finalize your activities for the last months of the project. I hope I'm not speaking Greek. If I am, it means the researchers have not done their work. That the parliament who signs the agreements with us have not done their work to institutionalize the project. I believe you are here and you are not hearing about these things for the first time, or that you are not going to say, we are not ready, we are going back, because you're already here. You already took our ticket, you slept in our hotel, you agreed to be nominated. If you have not, you have to work extra hard so that when you stand before us, you deliver as expected. You'll also be required to look at combined figures according to the focus areas so that we can develop a regional outlook of expenditure For instance, on comprehensive sexuality education, on key populations, on safe abortion, among others. Maternal health, unintended pregnancies, all those issues which will be reported to Sweden and also stay as an archive for the project's own institutional memory. Colleagues, we require your diligent contributions for this exercise that will contribute to our ability to demonstrate Parliament's ability to monitor and evaluate information gathering processes which are already in existence in your parliaments. The Committee of Clerks meeting, which will take place on the 30 and 31 next week, will also be apprised of the results demonstrated so far for each parliament. So colleagues, this budget analysis session will also be an opportunity. It will be an opportune occasion for you to refine your thinking as you move to complete all activities in the final months of the project. I wish to emphasize that non-completion of activities will not be viewed with leniency in year 3 and may have a bearing on the renewal of this particular project for the SADC Parliamentary Forum or for your individual parliament. There is therefore no room for non-completion of activities, especially due to lack of planning or lack of coordination, because we are convinced that if there's any institution that's good at record keeping, it is the institution of Parliament. This being said, we continue to rely on your cooperation and your commitment to uphold the commitments of the SRHR project agreement in your respective countries. With these words, colleagues, I love you very much, and I'm looking forward to you smiling as you demonstrate how diligent you have been in your parliaments for the past 3 years, 2 years, 1 year, as we now put forth what we see and what we believe in what a parliamentary staff's mantle is made of. I wish you a pleasant session, and we are here to work with you throughout. Thank you very much.
Thank you very much, Madam SG. I will now hand over to the resource persons to take up the next session based on our agenda for today. Thank you. Over to you.
Colleagues, a round of applause to the SG. And another round of applause to you, ladies and gentlemen, for making time to be a participant, but not only as a participant, but also to contribute, isn't it, during this session. Having done that, I just want to see how many resource persons we have by a raise of hands. No, sorry. Those that are going to present from the various countries by a raise of hands. All right. Why really do we have to do budget analysis? Why do we analyze our budgets? Just a random question. Why do you think we have to analyze our budgets? It is a random question, and you must all be having answers to that. A budget being both financial and narrative. Why do we at one point analyze it? What is the objective for analyzing a budget? Zimbabwe?
Thank you. To appreciate our priorities financially and courage to policy.
Yes, to appreciate our priorities, whether they are aligned to policy, even our funding, is it aligned to what we really want to achieve, isn't it? What is the other reason? You've been doing this, ladies and gentlemen. That's Eswatini. No, there's Eswatini over there.
Oh, sorry. Yes, we also budget to know how much was spent and also fix mistakes if there are any, if the budget was overspent or not. Thank you.
Indeed, to fix mistakes, isn't it? Maybe we over budgeted or we under budgeted, and isn't it? So we need at one point to then try and realign our priorities to what is on the ground. The other hand, it was Lesotho. The same point, okay. There's a different point there.
Oh, thank you. While I agree with them, I think it all depends on at what stage the analysis is being made. Because we know the budget follows a series of stages or cycles. But entirely, the analysis for the budget is to determine whether the fiscal policy delivers the intended outcomes. Yes, not only the variance, whether you have under or overperformed, but the performance should touch lives of people in the communities. I think that's the general.
Thank you so much. Thank you so much for that contribution. Anyone who's, okay. That's Mother Girls.
Merci beaucoup. Je pense que l'importance d'intégrer, de parler du budget, surtout en ce qui concerne la SDSR, c'est que, en fait, le budget, c'est un instrument avec lequel on traduit les priorités publiques en actions concrètes. Et comme ça, si on n'a pas de budget adéquat, donc les engagements, que ce soit en matière de SDSR, en matière d'égalité de genre ou bien pour la santé publique généralement, donc ça reste vraiment difficile à réaliser. Et puis, pour la SDSR, quand on parle de budget, donc ça nous permet de voir, en ce qui concerne le financement pour les services essentiels, également pour les personnes vulnérables et même pour les populations clés. Je vous remercie.
Thank you so much. Thank you so much. Is someone, okay, that's Namibia.
Why budget analysis is to manage resources efficiently and achieve strategic goals and also measure the impact.
I like it, measure the impact of the budget. All right, okay. There was another hint, Namibia again.
I think to support transparency and also accountability.
Thank you so much. So what are some of the issues that we need to consider when we are analyzing the budget for this project? What are key issues? What are these key issues that we need to consider when we are analyzing for this project in particular? The key points that we need to look at. In terms of impact, what are we looking at? Yes, Eswatini?
I think we need to look at, does it align with the thematic areas of the project, specifically for SRHR or gender, climate action change, and sexual reproductive health. Thank you.
Thank you. Another hand? Yes, Mauritius?
Yeah, actually, also we need to know the availability of the data that is there so that we can know how much to invest and how much to give priority to the aims and the objectives aligned with the project. Thank you.
Awesome. Thank you so much. Namibia? Oh, I see your mic is on. Namibia?
Also, we are looking at the impact and also the outcomes, because as much as the money is allocated, are we getting the intended impact that we need or not?
Exactly. We have to consider the results. Are we getting the intended results, isn't it? Our efforts, the funding and everything that we do, at the end of the day, they must give us the intended results, isn't it? All right, having said that, ladies and gentlemen, I just wanted to gauge in terms of how we appreciate budgeting, in terms of how we appreciate issues of budget analysis. But I think we are really on safe grounds. So I will refer you now to the program and we move to the space session. Secretariat, maybe just to check with you, checking on my program, T is supposed to be at 10:20. Do we proceed or we break for tea? All right. While they're checking, we shall proceed to the next session, that is session 1, where we are going to have presentations from each and every country. I will start, ladies and gentlemen, with Botswana, which is on my left. So Botswana, prepare your presentation while the Secretariat is checking in terms of our logistics. ICT, you may help us. We need the presentation beamed. And as they are presenting, I want you to be taking notes. You are going to contribute in terms of what they should have added in their presentation, isn't it? Like what the SG said, we are all going to contribute. No one is going to be presenting and we just listen, no. We are contributing, we need to come up with outcomes, results, how in terms of how we can improve our presentations, isn't it? All right? Botswana, are you ready? Botswana, are you ready? Then everyone else, please hand over your presentations to Ronald. Please hand over your presentations to Ronald. A round of applause for Botswana as they come to present. Please capture the key points and the learning points, isn't it? Just open it.
Good morning, colleagues. I actually thought we'll be called last. The reason why I thought we'll be called last is because most of you who have been coming to these meetings, Botswana has not been coming up to present, I think, because Botswana signed the agreement this year, January 29th, the agreement to join this project that some of you has been doing or implementing for the past 2.5 years, I suppose. And then I was brought in March. So we really implemented anything. We haven't implemented anything. But we decided that we'll just not come empty-handed. We will engage with different stakeholders and request for different types of information and put together 2 slides just to show that, you know, we have joined and we will learn as we go in terms of how other countries are doing this work and how other countries are engaging in the budget process. So we've really pulled together existing data from government departments, from our national budget speeches, from different budget briefs. But we believe that we still have a lot of gaps in our data that we may need to improve, especially as we see how other countries are working around it based on the trainings that we may have received in the past. I'm going to be doing this with my colleague Onkopose, who's our Chief Financial Officer in the Parliament Finance section. We are one of those parliaments that does not have a budget office. She will speak more to it. But so we have, I think, 2 or 3 slides, really. Yeah. Like I said, because we didn't want to seem absent. So what we did, you'll see in our presentation, we have noted our data sources, which includes our budget speeches, our financial statement tables that she has. It's a government document, so it's credible document, and also the national budget briefs. So I'm going to ask her to come and speak to the numbers. I keep telling her that I know how to write, but when it comes to speaking to numbers, she's more knowledgeable than I do. But so I'm going to ask her to come and speak to the numbers like the financial people do.
Good morning. As my colleague has already introduced me, I'll just start to talk to the figures as they are projected there in the screen. We managed to extract data from 2022-23 to 26-27, which is 5 financial years. And as it is shown there, we've realized, we've seen that our national budget continued to increase over the 5 years period, with a slight decrease recorded in 25-26. But over the years, we've seen a decline in the budget allocated to the health sector. And the percentage of the national budget against the Abuja declaration has continued to decrease over years. Yeah, I can go on to the next slide. As shown in the graph there, we can see that from 22-23 financial year, the graph has been going up, while that is the blue one, while the one for the health budget has been going down. Our performance against the Abuja declaration has been decreasing from 14.52%, which was closer to the target in 22-23, to 8.25 in 26-27. I think one of the issues that my colleague might have highlighted is that our country has been experiencing some unfavorable economic conditions that we believe has led to has caused the government to review some of the policies. One of the factors that we managed to establish was the impact of inflation, which threatened the microeconomic stability and caused the cost of living of the population to increase. And as such, the government decided to increase the social protection to cushion the increasing number of favorable people. So we've seen, while the budget for the health budget continued to go down, we've seen more money be channeled towards social protection programs.
Yes. I think for the first presentation, this is the summary that we wanted to provide. Yes, really just looking at the national budget over the years and then the allocation towards health and noting the decline that for the past 5 years. Thank you.
Thank you so much. A round of applause, ladies and gentlemen. Any observations from the floor? Any key observations from the floor, from the presentation? There is none? Okay, what did we learn from Botswana? Raj?
Yeah, just an observation. Okay, so for Botswana, we see that post-COVID, that was quite high, 14%, which is more or less with target that we have on the Abuja Declaration of 15%. But eventually decline both on term of relative, but also an absolute amount, which is very drastic, but it's explained because of economic difficulty. So my question, what I wanted to ask is, whether parallel you have a private sector health, which is affordable, that so if there's decline on the public health, do you have a solid private sector health parallel and affordable to the people? That was my question.
Any other question?
So you're asking about private sector engagement in the health sector, right?
Yeah, I mean, the citizens, are they able to access private health sector, private clinic, private hospital?
Yes.
Is it affordable and it's available?
So in addition to the public health sector, there is a robust private health sector that people access as long as you have health insurance. And there are different types of health insurances. There is health insurance that is government managed and coordinated for government employees. And then most of the private sector employers also would have own private health insurance. And so most people from the private sector or most people who have health insurance would access services from the private sector. And the health insurance normally would work such that the employer contributes like 50%, and then the employee contributes the additional 50%. But even when we have private insurance, that does not exclude you from accessing public health sector services. Yes. Was that your question, Raj? Thank you.
Thank you, Raj, for that question. SG, he has a question.
I think Raj has been diplomatic. What Raj is asking, if you are showing that level of decline, there certainly is a gap, and the ordinary person on the street who was dependent on government is impacted. Where do they go? Are there systems in place to assist government, if at all, to make sure that those people are not lost? Okay. Or was there heavy dependence on government and therefore those people are lost? So have you observed? Because maybe you have not done the research further, but he wants to know, if all of us depend on government and government is what happens to an ordinary person? Yes. And maybe, well, I will say what we are talking, what our responses will probably be based on just our own personal observations and not necessarily the official whatever response. But I will say one fact. At some point last year, I think it was the State of the Nation address, when the president declared a public health emergency. Yes, I think it was the State of Nation address. But it was the public health emergency was fueled by the lack or shortage of medication from our central medical stores. It was mainly medication for your chronic illnesses such as your diabetes, your hypertension, and others. HIV medication, for example, so far we've not had any shortages. It's been highly protected in terms of the budget and ensuring availability. I know that we've had shortages of SRH commodities, especially for birth control. Those have been there, especially in the public sphere. And so for someone who doesn't have health insurance, if they go to the clinic and there's no medication for hypertension or there is no depot, then they don't have anywhere else to go. Just yesterday, as I was driving to work, there was a dietitian being interviewed on national radio. She was talking about hypertension and talking about healthy living, exercise, eat well, da, 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 da. But the questions that came were really about, there is no high blood pressure medication in the hospital. Where do I get it? And someone even said, even when you go to the private pharmacy, the supply has been exhausted because everybody is going to the private pharmacy to get such medication. So there are those. So the public health emergency was on national news. It's not a secret, it was there. And I've not heard of the lifting. Yes, but I do know that at that point, government partnered with the private pharmacists, especially, and private suppliers to buy all the supplies that they had at the time and stocked the different public health facilities to increase availability of medication at national level. So there was that response from the highest office. Yeah, but challenges do exist. Thank you.
All right, thank you so much, Botswana. In the interest of time, okay.
Sorry, just one question. I noticed that in your presentations, the allocations were consolidated. The proportion of health to the budgets, and there was a reduction from 2022 to 23, I think from 14% downwards. How are you able to tell how much goes to SRHR, in those budgets? Because it was very difficult for me to see that. It's very possible, for instance, that the money going to health, much of it is going to non-communicable diseases as opposed to other SRHR issues.
Okay, so when we did our presentation, our interpretation was that session one was just high level, like that. So that's how we interpreted the agenda. And so for the way that we interpreted it was that session 3 is when you go into SRH analysis and then speaking to the allocation for SRHR. Yes. Thank you.
So maybe we park that question, then they will respond later on in the day. All right, another round of applause. I think they did well. So we shall break for tea, just for 20 minutes. Then we are back, and the next presentation will be from DRC. Do we have DRC? They are online. DRC will present online. Thank you so much, colleagues. We meet in 20 minutes.
Okay, if DRC, they won't be prepared, Eswatini, please also be on standby. Thank you.
1, 2.
Okay, colleagues, can you check with your other colleagues from your countries so that we start? Otherwise, if we delay on time, you might find that we'll spend the whole day because we need to cover the whole program for day one. And if we start on time, it means then we'll also have the opportunity to knock off in good time. Thank you. So if your colleague is not there, please just send a message to them so that we proceed fast. Thank you.
One of the critical traits of a good analyst is being able to keep time, isn't it? So we shall try, ladies and gentlemen, to be strict with time. I'll speak with SG and the secretary so that at least we come up with some punishment for those that arrive late. Is it okay? Is it okay? All right. So the yes, you have it. All right. So let's be on time. Colleagues, we proceed, and the next presentation is coming from Eswatini. Can we give a round of applause?
Good morning, colleagues. I hope you're all well. My name is Anele Kwabe. I am an SRHR researcher for the Parliament of the Kingdom of Eswatini. Please forgive me, the presentation was a teamwork, so we did the information, but the IT team in our parliament did the design. So my slides might show up slowly because I can't edit. Also, okay. Okay. I'll just speak to the session that we're on because this is about 26 slides, so we combined everything. But basically, this was prepared for the Office of the Clerk to Parliament in collaboration with the Technical Working Group. In our Technical Working Group, we have different ministries and civil society organizations. We have Nature, SAFAIDS, Ministry of Health, Ministry of Tourism and Environmental Affairs, Ministry of Education, which speaks to life skills education. We also are trying to partner with UN agencies, but not as yet, but we'll also try to add them to the technical working group. Budget. This is our SRHR budget for the 3 financial years. For 2023, we had 2.4 billion. Sorry, we're not able to put it into
Excuse me, sorry,
USD.
We have a serious problem. The resource persons don't have your presentations and they are struggling to see so that they can give you feedback. So is it possible to email? You've already sent? All of them would need that so that they don't struggle. Otherwise, you won't have good input. Perhaps let's just wait for that to happen. There's a hand from Zambia.
Thank you very much for the opportunity to ask. Just for clarity and avoidance of doubt, are we presenting reports now? Or where are we on session 1 where we just give highlights on the approaches that we use in mainstreaming, just for a common understanding? Thank you.
All right, we are still on session one, presentation on the budget by national resource persons. With the objective being the session will provide concise refresher on the importance of the budget and practical approaches. Ladies and gentlemen, for mainstreaming SRHR and gender considerations within budget processes. That's the session. Or maybe let's do it this way. How many of you have 3 separate reports? So that you can present section A, section B, and section C. Or you have 1 consolidated report? What do we have? 1 consolidated report. Those with 1 consolidated report, can you raise your hands? That's 1, 2, 3, 4, 5, 6, 7. Okay. Those with 2 distinct reports, can you raise your hands? 1, 2, 3, 4, 5. Anyone with 3 distinct reports? All right. I will then propose proposal number 1. We present 1 consolidated report. That's proposal number 2. That's proposal number 1. Proposal number 2, we present 2 distinct reports. So, being a democratic person, I'll then ask the floor, what's your preference? We present 1 composite or we do 2? No, please raise your hands. 1 report, that's 2, 4, 6, 7, 8. You want 1 report? 9. All right. 2 reports. 2 distinct reports.
So, but
Then
according
then
to
it
the-
means it's gonna take a bit of time because we want you to then present your report in detail. Is it okay? Are we good?
No.
Malawi, can you come
But
through?
according to the program, we are supposed to have 2 presentations.
Yes.
The first one, the second one is the group work, and then we present. The third one is also a presentation on the SRHR mainstreaming. So I think for the report, we are yet
No.
to submit the report, but we have just summarized what is in the report and present on the first session and also the third session.
Yes, what I'm referring to is the first and the third session. Yes, it's the first and the third session. Group work it's a separate issue.
So we have two
Two
presentations.
reports, yes.
Yeah.
Yeah, two presentations. So I'm asking some had consolidated those presentations into one, and some already had the presentations separated. So can we then say we present one consolidated report? Should I say the years have it? All right, so Botswana, you're not ready to do the second one? That's still okay? All right, I think then there is a consensus that we present one report and we critique each report, right? All right, so Eswatini, you can continue with your presentation.
So for clarity's sake, are we saying we are presenting the report now, then we will get to other presentations when we get to session 3? Is that what you're saying? Because some of us, like Botswana, Lesotho has 2 presentations. We didn't do the consolidated single presentation. We
Yes,
have-
you can't present both of them at once.
Okay.
You can do that, isn't it?
We can.
Yes. So let's proceed in that manner.
Okay, we present both presentations at
Two
once.
presentations at once,
Oh, okay.
session 1 and session 3.
Okay.
Are we clear now?
Yes.
Session 1 and session 3 put together. We are clear? So if you have 2 separate reports, you just present the first report, then the second report. Those ones with a consolidated report, you're just going to present one report. It's clear. Then the second session, don't worry about it. It's gonna come after, later in the day. All right, Eswatini?
Good morning once again, colleagues. Since it's a one report, it's going to speak to everything also on the sections because I'd also consolidated on child marriage, GBV, Abuja Declaration. So I'll just present everything now. Okay. The report was prepared in partnership with the Technical Working Group and also the Office of the Clerk of Parliament. However, it does speak to present an analysis of sexual reproductive health and rights and budget mainstreaming in the Kingdom of Eswatini for the past 3 years. Also in Eswatini, Parliament exercised its constitutional mandate over public finance through scrutiny of the appropriation bill, committee oversight, and post-budget accountability. The report was compiled under the leadership of the Office of Clerk to Parliament, reviewing the Appropriation Bill 2022-2023 to 2026 to 2027. Analysis of estimates of revenues and expenditure, committee reports, also in partnership with, consultations with line ministries, health, finance, education and training, and the DPM's office. However, data limitations were noted due to the absence of explicit SRHL budget tagging with the national budget frameworks. With our consultations with the Ministry of Finance, they mentioned that they don't have a single line for SRHL budgeting. However, it's mainstreamed with NCDs, malaria, TB, HIV and AIDS, cancer. Yes. The health allocation trends for the past 3 years. For 2022, 2023, We have 2.4 billion out of the whole budget that includes other ministries, which was 23.2 billion. So health was allocated 10.43% of the national budget. Have we achieved the budget declaration yet on that year? No, but we were close by. And also for 2023, 2024, the health ministry was allocated 2.79 billion out of an annual budget of 26.44 billion. National budget percentage was 10.55%. It increased. And then 2024, 2025, the health ministry was given 3 billion out of 29.42 billion, sorry. That means it declined because the national budget now is 10.20%. Then for 2025, 2026, 3.16 billion of 32.61 billion, and that is 9.51%. We are definitely declining from the Abuja Declaration. And then for 2026, which is this year, the health ministry was allocated 3.24 billion out of 36.92 billion. Still, it declined and we're currently on 8.79%, whereas the Abuja Declaration is 15%. So we're hoping maybe the next financial year, we are able to increase. I think also the reason when we're doing the consultations with the Ministry of Finance, they mentioned that all ministries have their own priorities. So allocating more to health will also affect other ministries. So therefore, sometimes the budget needs to be shared equally. Analysis of the health sector is that allocations over the review period shows that nominal allocations increased from 2.4 billion in 2022-2023 to 3.24 billion in 2026-2027. The share of the national budget allocated to health declined from 10.43% to 8.79%. This indicates that the growth in health expenditure has not kept pace with expansion of the overall national budget. Consequently, the kingdom remains below the 15% Abuja Declaration target and has in proportional terms moved further away from attaining the continental benchmark. The trend presents implications of sustainability of SRHR financing, particularly in relation to maternal health, HIV prevention, adolescent health services, and gender-based violence interventions. However, the Ministry of Finance indicated that in our consultations with them, that the nominal increases in health allocations have been observed over the review period. However, the ministry noted that while government remains committed to strengthening domestic health financing and competing national priorities and economic pressures, have not limited the progress towards the Abuja Declaration and targeting the target of allocating 15% of the national budget to health. Also, donor dependency remains as significant in SRHR, as we all know that since in some countries, so maybe I speak for my country, UNAIDS has, the donor has removed. So some SRHR activities were through UNAIDS, but that does not mean the government was not funding activities. It's just that the pace right now is slow. It's no longer faster as it was. Okay, I have mentioned those. Okay, for family planning, maternal health, adolescents, SRHR, HIV, STI prevention, GBV prevention and SRHR commodities. Mostly, as I explained, we were donor dependent, but also with our consultations with the Ministry of Health, they mentioned that they don't have specific SRHR checking as to because, for example, STI and HIV prevention, one medication can treat 3 sexual transmitted infections. For example, gonorrhea, syphilis, the drug basically can treat, one drug can be used to treat different STIs. So hence, for them, SRHR checking is very difficult and the budget is not directly to SRHR. So they speak to cancer, HIV and AIDS, TB. For us, HIV and TB, it's one thing in our country. So SRHR tagging, we currently do not have, but that does not mean we're not going to work on it. And then information from the Ministry of Finance is that they do, I think the reason I wrote SRHR is that they do speak to sexual reproductive health and they do allocate the ministry. It's not much money to the Ministry of Health, but in the financial years for 2023 to 2024, they were given almost 1.5 million. For 2024 to 2025, they were given 4 million for SRHR. 2025 to 2026, they were given 3.6 million. And 2026, this year, they were given 4.5 million for SRHR, basically family planning, STIs prevention. And they also mentioned that they normally use some of these monies for visiting constituencies, more advocacy on HIV prevention. And they also work with civil society organizations, SAFAIDS, FLAS, family planning organizations. UNAIDS has also contributed on condoms. So the government was not buying condoms as much. UNAIDS had offered to contribute towards that. Oh yes, here's the analysis from the Ministry of Health, is that they do not have an SRHR standalone budget for all other components for family planning, which has a budget that runs via the central medical stores. And family planning commodities are procured via a third-party procurement that they had an agreement with UNFPA in 2023, which they entered to. So therefore, UNFPA serves as, I won't say a co-funder, but helps fast-track the process in case if the Ministry of Finance is unable to pay on time, they pay, and then the Ministry of Finance pays UNFPA. Oh yes, here are the SRHR allocations from the Ministry of Finance for 2024. It's the 1.2 billion that we're seeing on the chart. And then 2024, 2025, it's the 4 billion almostly. 2025, 2026, it was 3.3 million. And then this year is 4.2 million. However, SRHR financing in Eswatini is characterized by fragmentation across ministries and partners, also heavy reliance on development partners, particularly related to HIV-related interventions, emerging domestic prioritization of maternal health and GBV prevention. However, when we're preparing the report, consultations with the Deputy Prime Minister's Office, which speaks to social welfare and GBV, revealed that GBV and child protection interventions continue to experience a growing demand for services and constrained financial resources. They explained that they have one-stop centers. So some cases related to GBV cannot be reported on time. And also they have a manual system of collecting data related to GBV because they work with organizations like the Royal Eswatini Police, the Ministry of Health, SWAGA organizations, and collect all the data of all the people that have reported GBV, and they meet to collect the data manually. So for now, we don't have a database where you can go and search on GBV cases and issues of rape and partner violence. But they did mention that in cases of GBV, from their records and perspective, people are violated mostly by their partners. Also transactional sex is a contribution towards gender-based violence. They also mentioned that, however, men are now coming up to report cases related to GBV, because mostly, maybe let me speak to my country, culturally, a man is supposed to be masculine, so they can't come and report GBV cases, but they're seeing progress in more GBV cases, men coming to report, and they support them. Sorry, let me continue. Our budget allocations demonstrates alignment to SDG 3, which speaks to good health and well-being, and SDG 5, which is gender equality, and the National Health Sector Strategic Plan. Also, we have observed that through the implementation of the national legal and policy frameworks, including the Sexual Offenders Act, Sexual Offenders and Domestic Violence Act 2018, and the Child Protection Act Welfare, and the National Strategy to End Violence in Eswatini 2023 to 2027, which collectively strengthen government response in gender-based violence, child protection, survivor support services, and access to justice. The national strategy, however, emphasizes that multi-sectoral coordination, health system strengthening, prevention of violence, and improved access to psychological and legal support services. However, the strategy for ending violence is done through the DPM's office in collaboration with UN agencies. As I mentioned, that they do have per se psychological centers, social workers that are able to assist people who are affected by GBV. Gender responsive and equity focused budgeting. Parliament has progressively incorporated gender responsive budgeting principles, although institutionalization remains in its early stages. Our key practices is that committee level interrogation of the gender impacts of budget allocations. It includes vulnerable groups in oversight discussions, consideration of real aspects, disparities in service delivery. That means that I think last year we had 2 constituency visits from Parliament, visiting people in communities. So we do contribute to rural access. And the impact is that there's increased visibility of GBV related funding, increased advocacy for maternal health services. As I mentioned during the constituency visits, they spoke about SRHR. Firstly, we don't encourage, they were the youth, so we don't encourage the youth to engage in sexual activities. Firstly, we promote prevention. I think that's our structure. We promote prevention first, but during the constituency visits, it included the youths, people living with disabilities, and also the community members. And then on impact, we also have improved focus on underdeserved communities. Still continue on gender responsive budgeting. The national strategy to end violence in Eswatini identifies women, children with disabilities, orphans, vulnerable children, refugees, underdeserved communities as populations disproportionately affected by violence and unequal access to services. Parliament oversight and committee engagements have therefore increasingly emphasized that equitable allocation of resources towards GBV prevention, survivor-centered healthcare, psychological support, child protection services, and access to justice for vulnerable populations. During our consultations, they mentioned that gender-responsive interventions currently include community dialogues, parenting programs, because some of the GBV cases revealed that fathers do violate their kids. So now they want to check, and also the upbringing of the perpetrators is important, because some people have maybe were abused in their early stages. So that's why they tend to be violent with others. So they firstly have parenting programs for counseling, and they also have youth empowerment initiatives, positive masculinity campaigns, as I mentioned, that men are now coming to report cases, therefore masculinity is no longer a problem. They also have sports tournaments, radio programs, and they also visit the local, I don't know what you call in your countries, but bus rank, to ask conductors, also capacitate them. They have branding on transport that speaks to GBV. Also, traditional leaders are visited in chiefdoms, youth groups, women's forums. Women's forums, they encourage women to start businesses and how to make money to avoid transactional sex. Men's forums also continue to play an important role in promoting gender equality, violence prevention at community level. I think this is section D, parliamentary influence on SRHR financing. Parliament engages through pre-budget states, which committee consultations with the ministry. So the Ministry of Finance calls all ministries during the pre-budget stage to state their priorities. Parliament is also there. And then we have the approval stage where there's detailed scrutiny of the budget estimates, implementation stage, oversight visits to health facilities, and also the audit stage to review of the auditor's general reports. However, during the consultations, the Minister of Finance explained that Parliament engagement in the budget cycle is completed by pre-budget consultations involving line ministries, principal secretaries, planning officers, technical departments. Ministries are required to submit a budget framework, programs, priorities within approved expenditure ceilings. The ministry further indicated that consultation seeks to align national priorities. Therefore, I think in my previous slides earlier with the Ministry of Health, in terms of achieving the Abuja Declaration, it's just that all ministries and government departments have their own priorities. So they have a bit of trouble in allocating more money to the Ministry of Health. Child marriage and protection commitments. Budget provisions supporting child protection include education subsidies to retain girls in school. So there's education programs that help retain girls in school, community mobilization programs, social welfare support under the Deputy Prime Minister's office. The office indicated that there's a growing concern regarding gender-based violence that affects adolescents girls, they also mentioned that during COVID, there was an increase in teenage pregnancies. So they saw that retaining girls and boys in schools can stop teenage pregnancies. That's why hence the retaining of girls in schools. They saw a high increase during COVID of teenage pregnancies. There's also community awareness programs, mentorship initiatives, parenting dialogues are implemented to address harmful practices and strengthen protection mechanisms for children and vulnerable groups. Government also continues to implement the Child Protection and Welfare Act, Sexual Offenders and Domestic Violence Act, and the National Strategy on Ending Violence 2023 to 2027 through a multi-sectoral coordination framework involving Parliament, law enforcement agencies, health institutions, education stakeholders, civil society organizations, and traditional leaders. However, I don't want to say child marriage is not a problem in my country, but with the Office of the Director of Public Prosecutions, they reported that child marriage cases are always formally registered as standalone offenses. Matters involving children frequently arise through prosecutions related to sexual offenders, adoption, domestic violence, trafficking, and child exploitation. However, they said they also work in hand in hand with the DPM's office and the Royal Eswatini Police development partners in implementing stakeholder trainings, awareness programs aimed at child protection systems and preventing abuse and exploitation of children. Child protection interventions include implementation of Umphakathi Child Justice, Umphakathi standing for chiefdoms, restoration justice initiatives, development of child justice process flow guidelines, regional trainings for police officers and prosecutors, and survivor-centered approaches to handling child protection in GBV cases. Parliament has exercised oversight through committee engagements and alignment with regional frameworks in addressing child marriage. Oversight, transparency, and participation. Portfolio committees, inquiry and reports. We had field visits, which is the constituency visit I was talking about, which is taking Parliament to the People program. Budget hearings and stakeholder consultations. Tracking of the Auditor General's findings through the PAC. Oversight engagements on implementation of GBV legislation, survivor-centered services, and one-stop center initiatives. Public participation in Eswatini is facilitated through stakeholder submissions through committee processes, engagement with civil society organizations and development partners, inclusion of community concerns, and committee reports. Our data sources, we use the National Health Statistics, ministry reports and sector reviews, development partner publications, the UNFPA, World Health Organization, and the UNICEF. The key gaps we identify was the absence of dedicated SRHR budgets clarification, limited integration of data systems and across sectors, reliance on manual GBV and child protection data management systems continues to affect timely reporting and coordination among institutions, limited availability of integrated digital systems of national GBV and child protection monitoring. Stakeholder consultations also revealed that some institutions continue to experience challenges with disaggregated data collection, monitoring systems, and statistical reporting on GBV, SRHR, child protection, and violence-related cases. also the Office of the Director of Public Prosecutions noted that absence of dedicated monitoring and evaluation specialist limits comprehensive analysis of trends relating to child protection, sex offenders, and GBV implementation outcomes. Key achievements speak to increased parliamentary attention to SRHR financing, which is something we need to work on as Parliament. Improved integration of SRHR issues in committee work. We have a technical working group where also our senior HR is part of the technical working group. Strengthen collaboration with stakeholders. Our next steps or priority areas for the next budget cycle is scaling up adolescent SRHR services, strengthening maternal health infrastructure in rural areas, which is more advocacy, and enhancing domestic financing to reduce donor dependency, strengthening SRHR budget tagging and expenditure tracking systems across ministries, support that we need is technical assistance from the SADC Parliamentary Forum, capacity building for Parliament staff and committees, and improve data systems for evidence-based oversight. I think the presentation ends here. However, we are in progress of mainstreaming SRHR within the national budget. The role of Parliament has been central in advancing oversight, advocating for inclusive resource allocation, and sustained progress will depend on consolidating institutional capacity, improving data systems, and deepening collaboration between Parliament, the executive, regional parliament, under the SADC PF framework. Thank you.
She deserves another solid hand of appreciation. All right, thank you so much, ma'am, for a comprehensive report. I'll then take it, present it to the floor for observations, areas of improvement. Any contributions from the floor pertaining to the presentation? Raj? What's your observations? Raj? Yes, yes.
This was a very comprehensive presentation in itself. It will take time for us to digest the whole thing, but it was very conclusive the way it was presented. Just a caution on figures. On the first few slides, there was figures. So this is Eswatini currency. So colleagues from South Africa, Namibia, even Botswana and Lesotho will have no difficulty. For colleagues outside the SACU, you need to divide it by 16 to get US dollar so that you can compare it. So that also could have been an improvement if on the presentation, if we can edit, put it in bracket the US dollar so that we will be able to see. But also some other things, even on the first presentation, this one and another, I wanted also to see what is the contribution of donor toward health sector. You know, in some countries, it is what we call off-budget funding. So actually, they don't put it in the budget and you will not even know. I take a simple example just on polio eradication. Do you know it's like 100% financed by donor? So it's a big contribution, but you will never find it in any national budget. So that also do affect when we say percentage budget to health. Upon that, that was very good. I really appreciated the presentation, and I think it will be shared to all of us. Yeah, it's good. Thank you.
Thank you, Raj. Any other contributions? That's Madagascar.
Merci, monsieur, de m'avoir donné la parole. Peut-être que j'anticipe un peu, mais je voudrais rebondir sur le dernier point de la recommandation.
Can you wait a minute? Can you wait a minute?
Je peux?
Yeah, please proceed.
D'accord. Donc, je disais, j'anticipe un peu, mais je voudrais rebondir sur le dernier point par rapport à l'insuffisance du budget en termes de ressources nationales, parce qu'on est très dépendant donc des ressources des partenaires. Est-ce qu'il y aurait des pistes de solutions concrètes pour établir ça, justement? Parce que pour moi, un budget, ça signifie prévisibilité. Et donc, si cette prévisibilité-là n'existe pas par rapport au financement des projets SDSR, aller dans une pérennité ou établir une tendance sur le long terme pourrait s'avérer difficile, à mon sens. Donc, je réitère la question, est-ce qu'il ne serait pas temps quand même d'établir des mécanismes, peut-être mécanismes régionaux, pour mettre en place un financement pérenne pour nos pays respectifs? Parce que Madagascar a exactement le même problème aussi. Voilà, merci.
Do you want to respond to that? I will respond to that later. Can we move to the next one? Next observation? I've taken note of your observation. I'll respond to it. Any other observation from the floor? My fellow colleague, your comments, observations?
Thank you. I mean, just a few comments on the presentation, and that was a very good presentation, by the way. It was quite elaborate. I notice consistently that we are saying the budget is not specific to SRHR. We have spread across the different ministries. And for me, I think that was expectation, because I didn't expect that to have a consolidated budget SRHR. I sit in one of the committees in Zambia advising, and my colleague from the Parliament of Zambia can attest to this. When they changed their budget process to include all committees to provide or to approve the budgets in committees, I started seeing that problem being solved, because the analysis was coming down to heads of expenditure, each ministry. And you know, colleagues, that committees of parliament provide oversight on a particular ministry, or ministries as the case may be. So each committee, when the budget is presented, begins to sit in different rooms, all committees. So they will be looking at each head of expenditure. So you can actually see, for example, under Ministry of Health, that there are matters related to sexual reproductive. You can literally see how much went to this. You can see in agriculture, you can see in education. You can actually begin to tease them out and add them at the end of the day. So because SRHR issues are cross-cutting, you know, they affect agri, they affect education. So maybe going forward, we should even begin to say, to stop thinking about consolidated budget on the SRHR, because it can't happen. It sits across different ministries. I thought I should just bring that out so that staff can be able to appreciate it from that perspective. Is there anything? The issue of the Abuja Declaration, the budget that goes to the Ministry of Health, for instance, the budget that goes to health sector may not necessarily go to SRHR if you're looking at it from that perspective. In Zambia, for instance, where my colleagues are coming from, you'll find the budget is going towards health, but much of it is going to non-communicable diseases, cancer, these other big diseases. And the issues of sexual reproductive health or SRHR seems just a small amount. So if you are looking at the bigger picture of 15%, you actually might lose the focus. Well, you might discover that very little resources actually are even going to SRHR. A big chunk is going to ministers traveling for treatment abroad, that kind of thing, and very little. And I think that we should take care of those small challenges as we proceed, especially that our focus is on SRHR budget. I thought I should bring up those issues. Thank you.
Thank you so much. You mentioned the technical working group. I was keen to understand the composition of the technical working group and who facilitates the meeting of this technical working group. Then maybe before you answer, if you can go to the slide on gaps. The slide on gaps. I want us as a team to look at these gaps that she has identified as a presenter. I know they may relate to Eswatini, but somehow they may also relate to our different countries, isn't it? So I want us to practically challenge those gaps and maybe come up with solutions in terms of addressing each and every gap that has been identified there. We have the capacity to do that. So let's go item by item, each gap, how do we address this gap? What recommendations can we proffer to address the identified gaps? Let's slide before that. All right, we have key gaps there. The first one being absence of a dedicated SRHR budget classification, limited integration of data systems across sectors, reliance on manual GBV and child protection data management systems continue to affect timely reporting and coordination among institutions, limited availability of integrated digital systems for national GBV and child protection monitoring. Then the last one being stakeholder consultations also revealed that some institutions continue to experience challenges with disaggregated data collection, monitoring systems, and statistical reporting on GBV, SRHR, child protection, and violence-related cases. How do we mitigate these challenges? One by one. Let's caucus and present solutions. That will be the key takeaway of this meeting, isn't it? Let's brainstorm. How do we manage these gaps? What interventions can we proffer so that these gaps are mitigated? Are we together? Anyone who is ready to respond? Then coming to the issue of a regional mechanism. Oh, okay, Malawi.
Thank you so much. I want to take gap number, absence of a dedicated SRHR budget. Like in other countries, like Malawi also has no dedicated SRHR budget. But then we have SRHR programs. They have their own budget allocation. We can find them in the program-based budget. We find allocation on HIV, we find allocation on family planning services, allocation on youth-friendly health services. That's how we come up, we identify SRHR allocation. So what we did in Malawi is to also lobby for establishment of budget line for youth-friendly health services proper. So our members of parliament, they managed to lobby for it. And from 2023, 2024, we have the budget line for SRH, youth-friendly FSFCs. So to tackle gap number one, we can still lobby for establishment of specific budget lines for specific SRHR programs so that our members of parliament do their role of lobbying for that establishment of budget line. Thank you.
Awesome. Thank you so much. A practical intervention. Thank you. Another one?
Maybe just an extension,
Yes,
an
ma'am.
extension to that. The question should also be maybe how many countries have adopted the program-based budget? I don't think all of us actually do have that. In Malawi, we have that now, and like my colleague mentioned, we're able to see breakdowns of the specific lines in each and every board. So how many countries actually do have the program-based budget? And also an important aspect of this PBB, it actually links the budget to actual outputs on the ground. So it's maybe something we need to start talking about. Countries should adopt this PBB. Thank you.
Okay, introduction or adoption of program-based budgeting. That's another intervention there. Any other contribution from the floor? Just pick any of the gaps that have been identified there. Yes, Botswana?
Yes, so thank you, Shatini, for the presentation. I think for me, the one that's when I look at the gaps here, I can identify with these gaps, but I realize that there are two themes. The first one being the budget classification that colleagues from Malawi have just spoken to, and I've just confirmed with our data, with our budget POC that we also don't have program-based budget. But I also wanted to note that the other, at least 3 of these gaps are all, even the 4th one, are all data related in terms of data systems, in terms of M&E systems, which I think also most countries probably have that issue as a gap, especially the limited integration of data systems across sectors. We saw that also as we were compiling information for this meeting. There are gaps that exist. You go to a Ministry of Health, for example, you may get data for commodities, but even then you'll get what they classify as SRH and then maternal health, but then you don't have maybe data for anything else in terms of commodities. But even then, like a Ministry of Health, because most of this disaggregates are within that ministry, but they're not under the same, like they may be under the broader Department of Public Health, but then under Department of Public Health, there are specific units. And so you may be able to get data from one unit and not from another. So that just makes your data incomplete for most of the time. So I think even as the issue of data, integrated data systems will probably come across as a major gap. But just to say, I recognize these gaps and pretty much identify with the same gaps. Thank you.
Thank you so much, Botswana. Mauritius.
Thank you. Actually, addressing SRHR budget gaps requires a multi-sectorial and also an evidence-based approach. When we talk about it, it's usually about strengthening the SRHR budget tapping, improving parliamentary oversight, as well as the institutionalization of the gender-responsive budgeting. And when we're talking about how can we enhance the interministerial coordination and increasing domestic financing. And I think we all have mentioned in our report, it is also important to align the SRHR allocation with the SDGs. And when we're talking about those SDGs commitment, it comes with demographic realities whereby the actual service delivery need to be that kind to ensure equitable as well as sustainable outcomes. Thank you.
Thank you so much, Mauritius. Mozambique.
Obrigada. Dizer que
Just a minute. Yeah, please proceed.
Obrigada. Eu gostaria também de me juntar aos colegas que me antecederam, dizer que é uma lacuna, mesmo a nível de Moçambique, a nível dos nossos relatórios, temos tido essa lacuna. É difícil termos aquilo que são os valores reais para a área de saúde sexual e reprodutiva. Às vezes é difícil termos esses valores porque o orçamento é alocado para o Ministério da Saúde e, a nível do Ministério da Saúde, eles fazem a devida redistribuição. E pode-se dar o caso de ser definido como prioridade, por exemplo, a questão de saúde sexual e reprodutiva ou planeamento familiar. Mas, na aplicação, durante a implementação do próprio plano de atividades, pode haver aquilo que se chama de desvios de aplicação. Pode-se dar o caso de, durante a implementação, julgar-se pertinente, por exemplo, a alocação de recurso, por exemplo, para a malária. Então, acaba prejudicando aquilo que estava previamente estabelecido, que era, por exemplo, saúde materno-infantil. Então, muitas vezes acontecem estas questões de alocar-se um determinado orçamento, mas no momento da execução, haver estes desvios de aplicação, em vez de ir exatamente, por exemplo, para a área de saúde sexual e reprodutiva, ir para a malária, por exemplo. Ou pode aparecer um surto e achar-se que é prioritário resolver a questão deste surto e fica em detrimento daquilo que é, por exemplo, saúde materno-infantil. Então, é importante, talvez, no âmbito da fiscalização, os parlamentares devem prestar muito mais atenção, saber exatamente o que é alocado para esta área de saúde sexual e reprodutiva e se, de fato, este valor é implementado para esta área. Então, é um desafio que levamos também para assessorar os nossos parlamentares no âmbito da fiscalização ao governo. Muito obrigada.
Thank you so much. Then the last one is South Africa, yes.
Thank you. I think much has already been said about the data challenges, and I want to just offer an example from South Africa to say that our National Department of Health adopted a national integrated SRHR plan in 2019. And so the department itself took it on itself that they would try to figure out as a department the line items of allocations that are going to sexual reproductive health. So I think it's important that not just Parliament do this work, but that you have a department that actually has the information across board. So the National Department of Health said they would ask the provinces to provide data, and they themselves have data, right? To what extent that's been implemented, now that's a Parliament function. We must ask how far have they implemented that? But I think it's to say, who is the most likely to actually have that data? Because when you look at SRHR data, we're almost at a hospital level. We're not even, so there's the national allocation, it's gonna go to whichever departments. In South Africa, health is a provincial function, so provinces are gonna decide how they allocate health versus education, right? And then you're gonna have local initiatives. So in a way, you almost have to track it all the way to kind of where does it land? So I actually want to propose a different way. I know this is about budgets, but I think for me, what is more important is outcomes. So the budgets can look like they're increasing and the outcomes are not getting better. The budget can look like it's decreasing and the outcomes are actually getting better. right? So it can go either or. So I think in our analysis of budget, the emphasis really should be about bang for your buck, as Americans would say. What is your bang for your buck? What is the actual outcome that you're getting out of it? And I guess the other thing I wanted to offer is to say the lessons from gender responsive budgeting, at least from the Australian Femocrats, as we call them in the 80s, is that they also realized that overlap, which somebody's already mentioned, this idea, and I think our sister from Eswatini already says that there's one medication that heals 3 things, or so forth. So I think then the challenge, which has always been there, is the question of double counting always. And I think what the feminist Femocrats said is that when you look at gender, 99% of the budget actually can't be allocated by gender in Australia. They said only 1%, which says women programs could be allocated to women programs, but the rest of it, they actually couldn't allocate it. So I guess to caution to say, the deeper you go, the harder it might be to actually allocate where are we doing SRHR, especially when we get to departments of like education, when children are being taught about sexual reproductive care in the South African Life Orientation Program. Do we say that proportion of spend on basic education, which we can't actually account for, goes towards SRHR? I don't know, you tell me, right? So the question is where and how do we determine what then goes into that, except for the obvious programs, HIV and AIDS program and so forth. So that's all I have to offer and reflect on.
Thank you so much. SG, you can agree with me that the workshop has started now. The key takeaway, we still have another one. I think that's the last one from Zimbabwe.
Thank you. Probably I just want to share some experience around gender responsive budgeting. In that, the Minister of Finance during national budget presentation, alongside the national budget statement, is also obliged to present a gender inclusive budget statement, which is basically reflecting how the fiscal resources are going to be allocated to ensure gender equality, and also around the whole of government approach to mainstream gender. So it's basically a starting point when we analyze budget responsive within the ministries or around government in Zimbabwe. So probably it's an experience that colleagues might be able to also observe from Zimbabwe. Also around my contributions around evidence or data on budgets regarding SRHR. We have the same scenario where we have the same scenario where the allocations are fragmented across ministries, and you would find that in other ministries they are not per se regarded as an SRHR allocation. I can give you an example of, let's talk of a BEAM, a basic education assistance model. It's a model for assisting the disadvantaged peoples or learners to the public service. It's a social net just to cushion the disadvantage. But for us, we then look it from a lens of SRHR. We then argue that probably we are keeping the girl child at school. We are able to prolong pregnancies or avoid teenage pregnancies and STIs and HIV and AIDS. So basically, this is the kind of challenge that are there. So we will then try to balance by tracking those allocations. Thank you.
Thank you so much, Mr. Chiremba. I think that wraps up the first presentation from Eswatini. Can I call on to the podium for another presentation, Lesotho? Whilst we acknowledge you with a round of applause again. Lesotho? Then there was a question is, how feasible is it to develop a mechanism to cater for the funding gap within the region? Already we have noted that the majority of countries haven't been able to at least attain the 15% Abuja Declaration. Is it possible now to develop a mechanism, a framework that would then push all these countries to at least address the funding gap? Given that already their dynamics are in the world where donor funding itself is actually on a declining trend. It's a question for another day, isn't it? All right, I'll allow Lesotho to present.
I think that, like I brought out earlier, the idea of looking at health from the Abuja Declaration has to be conducted with a fine lens. Because sometimes governments will show you that they've allocated 15% of the budget towards health. However, when you tease out, you'll find that very little actually is going to sexual reproductive health. So the bigger picture gives an impression as if there's a lot of resources going to health, but within the health sector, within that, you find that very little is going to sexual SRHR. And that's why I think I want to support the recommendation by Malawi that it's important that we go into programs as opposed to, and the South African arrangement, because that becomes easier now. You can look at the different programs and say how much is going to hospital services and how much is going to primary health care, for instance. Then you begin to center on the primary health care and be able to tease out the SRHR issues. I thought I should just bring that up. I think.
Yes. Thank you and good afternoon. Today I am not alone. I'm with my colleagues from the Parliament. So the first presentation is going to be done by the Budget Office. Thank you.
Next slide.
Okay. Good afternoon, everyone. Program Director, I think before we start, we have to confirm which one is the king in the house. Looks like we have two kings, but there can only be one. My name is Lereko Maine. I come from the Kingdom in the Sky. From the Budget Office. Mine is very simple. I think as the youngest, I'm only six months old. How is that possible? I'm only 6 months old into the Budget Office, the Parliamentary Budget Office, which was just established last year in December. So the case of Lesotho here, as you will realize in our core message is that we take SRHR issues as very important, relevant, and the country is very much committed. But the broad message is that the budget does not yet make the issue sufficiently visible in their budget submissions. The SRHR are not tagged within the budget and to track them from the appropriation to commitment. As the previous speakers have alluded, we do recognize that the issue cuts across different government departments, ministries, and agencies. So the next slide. I think I need help. Yes. It's cut. Yeah, it's cut. It's really. Sorry about that. Our report has got a number of abbreviations, but since we are going to have this presentation, you'll go through the abbreviations and their explanations. But let us first understand the task at hand here. The scope deliberately limits us to examine the budgets from 2024, 25 until 2026, 27, which is 3 years. So we decided to strictly follow the SADC PF concept note, but the review tests whether Lesotho has visible SRHR specific budget line items or relevant policies, commitments, and broader sensitive sector allocations. Our understanding is for the budget to be approved in Parliament, there has to be a law that directs as such. So any country which recognizes the SRHR specific line items must have laws passed in their own parliament. We will see as we go. My colleague will take us through the legal provisions that exist in the country, which enable Lesotho to actually allocate the budget in the respective ministries. But because many budgets do not have line or a line called SRHR, the concept note, as we understand, requires tracing linked sub-budget lines, such as gender-based violence, maternal and child health, child marriage, reproductive services, universal health coverage, and HIV. So I will hand over to my colleague to give you a preview of legal provisions that exist in the country.
Thank you very much. I also have to introduce myself. I am Mosito Ledimo. I work as a chief researcher in the Parliament of Lesotho. Basically, what happens is that Lesotho is now going through some reforms. You know that, I'm sure most of you know that it was under the guidance of the SADC that Lesotho was going through some constitutional and some other structural reforms. With the new constitution, of course, with the previous constitution or the new amendment, what we call the 10th amendment to the constitution, the parliament has the power to scrutinize any budget that comes to parliament, including the SRHR. And it also has the power, in fact, to scrutinize the expenditure and the performance by the related MDAs. The 10th amendment also introduces the new office, as my colleague, Mr. Maine, has just informed us that he is new in office. This is due to this this provision that establishes his office. Basically, what you will realize with the Parliament of Lesotho is that before the introduction of this new office, the budget was only passed, but not really, it was scrutinized, of course, but for the first time this year, there were some guidelines put in place by the budget office, such that for the first time, there were some analytical submissions which were given to the members and also submitted into the House of Parliament. This creates an institutional provision for technical budget analysis. And as a matter of fact, we have some tracking and dashboards and committee scrutiny. This year we have had that. The 10th amendment also has introduced a new thing which was not constitutional. Of course, some other pieces of legislation did recognize a child as somebody under the age of 18. But with the new amendment to the Constitution, we have a child as anybody under the age of 18. This has strengthened the case for the young people and children, adolescents, and issues of gender and marginalized groups in terms of budgeting. The 10th amendment also raises the matter of public interest, and therefore it obliges strict consultation. This has, in fact, supported accountability where rights are threatened or services. Children's protection, welfare, and it's Children's Protection and Welfare Amendment Bill. Unfortunately, this bill, much as it contains much of very important items, the Senate has withheld it. We have a two-house chamber, we have the National Assembly and the Senate. If the Senate may realize some other factors within a certain bill, they can hold it. That is the power that they wield. So the bill, much as It is this old, it has not been enacted or become a law, a piece of legislation. As a matter of fact, it links child protection access to health services, education. It also explores matters of trafficking and exploitation to children, and it protects the structures that lead to budget needs. We have the HIV policy. The HIV policy is a bit old, but it is one of the major instruments that oblige Parliament to review whether there is a need to criminalize HIV infection, but there is a fear in some way that it might undermine factors such as testing, treatment and uptake, and anti-stigma commitments. We also have another piece of legislation. It was enacted in 2022. That is the harmonization of the rights of the customary widows with the legal capacity of married persons. The Legal Capacity of Married Persons Act, which was enacted in 2006, obviously focused primarily on civil marriages. This, in one way or the other, was excluding women who were married under the customary tradition. This piece of legislation managed to remove the minority status on the customary widows over independence, ownership to property, access to credit and inheritance. Unfortunately, with regard to our budget, it is not visibly reflected within the SRHR component, but it is there and encapsulated in the Ministry of Justice as part of the justice system. We have the education policy. Here we must indicate the reality that although the policy talks about the WASH, that is the matter that has to do with sanitation, water sanitation, and some cleanliness regarding the schools, it says nothing with regard to matters that have to do with the SRHR. But what we noticed as we were preparing this report, we were informed by the experts, by the people responsible within the education domain, that with regard to sanitary pads, the inspection manual for secondary schools obliges that each school should have some sanitary pads at school. For the school to be proper, it has to have some sanitary pads in order to provide for girls who may need them during the course of the day. We also have the PFMA Act. It's a bit old. It was not, we cannot talk about it as something that has been induced by the SRHR project. But all that we have to mention here is that it apparently doesn't oblige the Minister of Finance to say anything or to make any statement or to refer to regional or international treaties or conventions when making budget submission to Parliament. But there is a significant development as we are moving. Currently, there's a draft act or the draft bill that is already under review, the new draft bill regarding the PFMA in Lesotho. This team has committed to ensuring that when that bill will be submitted into Parliament, they will ensure that it incorporates all matters that have to do with SRHR, and of course, to include the components or the ideas proposed by the SADC model law on PFMA. It will also be realized that it will also be realized that analytically, it will also be realized that analytically, in our budget, we don't really have a visible or specific amounts named under SRHR. The SRHR matters are much more visible in donor-related funding, especially the MCC, as we are being funded specifically by the US here. We have visible policy commitments, but the SRHR in the budget submission does not really demonstrate a separate amount, which gives us some columns, in fact, to quantify the estimates to say that we have this amount specifically for the SRHR. The reality that obtains with us is that, yes, we have SRHR sensitive proxy envelope, or that is what we need. But the reality is this: it is not very clear in our documents. Okay, I'll leave it to Mr. Maine to continue.
Okay, that being said, ladies and gentlemen, let's check the past or the allocations over the past 3 years. We will realize that in 2024-25, the allocation in USD dollars in the Ministry of Health was merely 205, which was just 11% against the 15% of the declaration. In the next year, the budget declined, and as a result, even the percentage against the declaration fell to 9%. In 2026-27, the budget slightly increased from the previous year. However, the benchmark was still above because we fell to just 10%. So what we found is that Lesotho does not reach this 15% in any of the 3 years, even though the budgets in the ministry keeps going up. But since we agreed, the issue cuts across different ministries. In Lesotho, the load is shared between health, education, and gender, youth, sports, and development. But even those ministries together, they do not still specifically address the SRHR related matters. Even their percentages over those periods are still falling due. So the implication for the budget is that we need to have the oversight, which include or which coordinates the 3 ministries or any department that responds to the SRHR related matters. I think in the interest of time, if the program director allows, okay. We will go to this slide, which shows what looks positive and what is insufficient. What looks positive is that health remains a major public sector allocation in all 3 years. And the budgets recognize primary health care, maternal and child health, immunization, HIV and AIDS, disease prevention, and community health. As you may see, these are SRHR related issues, but they don't have specific lines feasible in the budgets. But Lesotho is not ignoring this issue. And the issue is that SRHR is not yet feasibly budgeted, tagged, reported, in a way that allows Parliament to verify whether allocations reach services and outcomes, or if the budget does have the impact down on the communities. What are the practical oversight questions that Parliament can have in order to help this issue to be appropriated? The evidence suggests that the approved budget by SRHR is still not checked, but the committee must have the baseline for scrutiny. We must know, there was a question as to whether we are using, like in African countries or Southern African countries, the program-based budgeting or not. I think if we could use activity-based budgeting, because in Lesotho we are using the ABC, it might be easy for us to include this phenomenon. As we will see when we next meet, the plan is to fully itemize the SRHR. It's a problem again here. Yeah. Program Director, as we finish, I think our point for next discussion as the office is how can Parliament institutionalize SRHR, gender SDG, budget statements, SRHR budget text, and quarterly evidence-based implementation reporting in the next budget cycle. That is our key point in front of our desks. I think we should stop here with our presentation. We didn't know how much time it would be allocated to us. So thank you very much.
Yeah, please, go, please.
ICT?
Sorry for that. Our apologies. I would like to just appreciate the presentation that my colleagues have just highlighted in terms of highlighting how the budget processes are being done in Lesotho. So I'm just going to briefly zero in on issues of SRHR, like they earlier on alluded to the fact that we don't have, like, you will not see the budget line that says SRHR, but all these issues are being embedded within ministries under certain headings. Like in health, we will find the SRHR issues being included under the primary health care. So when you look at our national context in Lesotho, the SRHR priorities are as listed. We have the universal health coverage through to social protection for vulnerable populations. And in terms of strategic alignment, the priorities are aligned with the National Strategic Development Plan. We also align with the SDGs, particularly SDG 3 and 5, and of course the SADC SRHR strategy and the UNAIDS sustainability map, as well as the national HIV and health sustainability agenda. So the national budgets increasingly emphasize resilience, inclusive growth, social protection, and health system strengthening. Sorry. So when we look at the SRHR budget mainstreaming approach, like we mentioned earlier on, Lesotho does not maintain a single SRHR budget line, and SRHR expenditures were thus identified across sectors and programs. We can see that the sectors from which the SRHR priorities have been identified, they are as listed, and the key priorities for SRHR budget categories, they are as listed on the slide. And this approach is consistent with the SADC PF guidelines and the SRHR mainstreaming. Again, when we look at the SRHR, I just want to talk to the SRHR financing landscape in Lesotho. When you look at the slide that is projected, you see that the SRHR is being financed from different sources. We can see that the government financing constitute about 37.1% share of the total health expenditure. And of course, the external financing is the highest with 56.2%, and the private or out of pocket, it's 6.7%. And this is from the analysis that was done by the National AIDS Commission, the 2026 physical space analysis. And this in itself indicates that the Lesotho's health and SRHR response remains heavily dependent on the external financing. And HIV and TB programs are particularly vulnerable to donor shifts. So this financing structure creates a major sustainability risk for SRHR, HIV and TB programs. And then when you look at the estimated budget and trends for the selected period, you see that for 2023-2024, when we look at the SRHR budget trends, you see that we have about 3.3 billion. And then for 2025, it was 3.7 billion. And then for 2026, it was 4.0 billion. So the main drivers for increased SRHR spending, we see that HIV and TB treatment, they include HIV and TB treatment programs, maternal and child health services, community health services, cervical cancer interventions, social protection, and nutrition, as well as health systems strengthening. So we can also safely say that although the nominal allocations increased, health remains under prioritized within the total government budget, averaging only 8 to 9% of the total expenditure, which is below the Abuja targets, as my my colleague has rightly indicated. And of course, when you look at the SRHR budget relative to national budget and GDP, you realize that for 2023-2024, we have health share of total government budget at 8.3%. And for 2025, it's 8.3%. And against the GDP, that constitutes only 9%. And the total health expenditure as percentage of GDP for 2023-2024, it's 6%. And for 2024-2025, it's 6.3%. And against the GDP, it constitutes only 6%. And the SRHR related spending as percentage of GDP for 2023-2024, it's 5.5%. And for 2024-2025, it's 5.8%. And this also constitutes 6% of the GDP. So Lesotho, when you look at it, you can say that Lesotho allocates significant resources to health relative to GDP. However, allocations remain insufficient to fully sustain HIV, TB, and broader SRHR priorities. And of course, the increase in debt service and wage bill pressure constrain expansion of physical space. So the debt service obligations exceeded the domestically financed health budget, particularly for 2024-2025. And then when you look at the donor shock and sustainability risk implications, I know Eswatini also highlighted on this issue because we are all experiencing the same because of donor cuts, specifically by the US government. So we can see that in our case, external health financing declined by 31%, HIV STI program budget declined by 48%, estimated funding reduction 500 million. And we can say that donor financing shock, when you look at this slide, that greater pressure on domestic financing, there's a greater pressure on domestic financing. We also see the reduced community service delivery, as well as significant pressure on HIV, SRHR, and TB programs. And the key message here is that the 2025 funding shock demonstrated the fragility of a health financing system heavily dependent on external donors. So the main successes and investments, when we are talking HIV and TB responses, Lesotho achieved 97% HIV diagnosis, 97% treatment coverage, and 99% viral suppression. And still on HIV and TB, you see that we have strengthened TB HIV integration and an expanded laboratory and viral load services. On issues of maternal and reproductive health, we have improved maternal and child health services, expanded reproductive health access, investments in adolescent and youth SRHR. And of course, when you look at the cervical cancer, we have had the expanded screening and treatment capacity, and of course the procurement of diagnostic equipment. And the community health and prevention, we have had during this period strengthened community health worker programs, improved nutrition and WASH interventions, and expanded GBV prevention and response, as well as strengthened protection for key populations. So we can see that our key achievement as Lesotho is that Lesotho remains one of the strongest HIV treatment performance globally. As I wrap up, when you look at the structural physical constraints affecting SRHR, we have major physical constraints. We have the SACU revenue dependency, where the country depends heavily on SACU revenue. So SACU contributes approximately 40% of total government revenue, and there's also a high volatility affects predictability of health financing. I'm rushing. And the second one is the wage bill pressure, where we can see that the wage bill consumes approximately 32% of total government expenditure. And of course, the debt service burden. The debt service absorbs approximately 9 to 10% of expenditure and more resources allocated to debt servicing than domestic financing of issues of health. And of course, as other countries, we are experiencing the low economic growth, the average GDP growth around 2%, and of course, the limited expansion of physical space. Therefore, the implication is that these structural constraints limit government capacity to expand financing on SRHR. And lastly, the public debt and SRHR financing, as we can see, as highlighted on the slide. So the key observation is that government spent more debt servicing than on the domestically financed health sector. So the consequences for SRHR will be reduced fiscal flexibility, delayed infrastructure investments, procurement challenges, constraints on expanding workforce, and increased donor dependency. So my last slide speaks to key challenges and obstacles, where we can see the financing challenges, the shrinking external donor support, limited domestic physical space, rising costs of commodities and health technologies. So I'm going to stop here because of time. You can just read through on the slide, and thank you very much.
That was for only one presenter. Can we have one big round of applause for the three of them? Thank you so much. I'll go straight to Raj. Your reactions? Raj?
No, that was really clear. I don't have any quick question on it. Yeah.
Okay.
Let me take the opportunity to thanks all the presenter from this very good presentation. Yeah, thank you.
Thank you, Raj. I'm sure Raj's mind is on the lunch that is a few minutes away from us. Isn't it, Raj? All right. Any observation from the floor? Zimbabwe?
Thank you. I've got a question. I would like to understand how are they responding or addressing the funding gap in view of the shrinking external support? Because I've noticed in terms of their budgets, I think there isn't much of a change from the previous years and also their 2026 budget. Thank you.
Okay. Can we have another question, observation? Mr. Marimo?
My apologies. I may appear to sound like a devil's advocate in this intervention. I want to acknowledge what Mr. Raj says, that the presentation is very brilliant on the intervention that Lesotho has done from a national perspective. But what I've not quite picked up is the parliamentary dimension. I don't quite hear the parliamentary voice. What has Parliament done, even as part of its oversight, representative or legislative function, to engender these outcomes? This would be perfect if, say, it was the Minister of Health making a presentation like this. But from an SRHR parliamentary perspective, I do not seem to pick up that voice.
A valid observation there from Mr. Marimo. You want to buttress?
Yeah, maybe just to add on for our colleagues from Lesotho, when Parliament is approving the budgets, is there a specific committee that sits or is approved or assembly on the floor of the House? Are you able to get some of these details that we are talking about from a committee perspective? I think that would be important to just buttress what is talking about. To what extent is Parliament involved in this work? Yeah, thank you.
Observation? Yes, Mr. Moses?
Thank you very much. Very interesting presentations. What struck me is that a lot of the presentations that were made, there appears to be very strong focus on identifying how much has been allocated So that's budget allocation. And not much attention on budget utilization and budget tracking, how much has actually been used and for what. I just thought I would raise that because I see quite a strong focus on allocations and scant regard to budget tracking to determine utilization and allocation. Thank you.
Thank you so much, Dr. Moses, for another valid point there.
Thank you. I am not going to respond alone. This time around, I didn't come here all by myself. I have my colleagues. For the first question, in terms of how we are addressing the funding gap, it's still a struggle. We can all agree that this is very new. The government is still trying to devise some strategies in terms of maybe seeing how we can tap into the domestic resources, which we can agree that they are not necessarily sufficient or they are not even there. So that one is still a struggle. We are still trying to find our footing in around the issue. When it comes to the issue of parliamentary engagement, yes, we do have committees. We do have committees whereby the budget is being scrutinized, where the different ministries sit with the members of parliament in terms of scrutinizing the budget and answering to members of parliament around the issues of budget. However, like my colleague from the budget office, we have been really struggling. I have really tried in terms of engaging with members of parliament to highlight issues of SRHR because we have this project within the system. However, I should also highlight the challenge that we have been facing as the project in terms of maybe aligning ourselves with the way things are being done in parliament. In Lesotho, what happens is that members of parliament get involved in issues of budget at the latter stage where they just approve something that was done by the ministries without necessarily being part of the prior processes of the budget. It's only now that with the budget office, we are going to, I'm hopeful that with the budget office in place this time around, we are going to do things differently. I have had an opportunity to attend the committee session. There's this committee called Social Cluster Portfolio Committee that most SRHR related ministries are under. So we made some recommendations, sorry, we made some recommendations around issues of the inclusion of SRHR in that. I don't know if I have answered that question, but in terms of advocacy, members of parliament are really trying, but I should admit that they are really limited in terms of making changes around the already completed budgets from the ministries. But I'm hopeful that with the new office, we are going to be able to maybe maneuver the system and do things differently.
Thank you so much, SG.
Thank you very much. Let me join. I've been in and out. I have a little emergency, but let me join all those who have come before for the great efforts and the presentations that have been made. This is work in progress. So as we go along and we get input, it should trigger us in terms of how we're going to improve and position Parliament's processes in the national process. So Mama Hela, colleagues from Lesotho, Parliament's are rubber stamping.
Yes.
Am I hearing it right? I'm just
Yes.
using the word.
Yes.
Are we saying Parliament's, the process as designed is only to rubber stamp? Are we saying that the committees and staff of Parliament don't have an opportunity to interface with Parliament? Are we also saying that the communities have no framework to influence? I just want to get it right. If there's a provision and if the time is limited or the resources are limited or things like that, I just want you to unpack that a little bit because you're going to be compiling and writing something that should really be understood in that context. I just want you to clarify that. Thank you.
Thank you very much. I think I may have to reply to this question. We cannot necessarily say Parliament is rubber stamping because the standing order provision also opens the floor for the public consultations or stakeholders consultation in everything that has to be done. But the reality that obtains is that with the budget, apparently the Ministry of Finance was working without involving Parliament. It was only maybe in the last 2 or 3 years that there was something like what statement, the midterm statement. That midterm statement happens to bring about the attention of the entire nation, such that there were submissions from the different stakeholders regarding the processes. Yes, of course, we may say it is rubber stamping as long as there are no issues that they don't feel like they have to be checked or addressed. But in terms of the legal provisions that we have, the Parliament even to amend it. For this year, we may have, I don't know if I'm right to mention this, but with the Ministry of Health, apparently there was a specific anecdote whereof the minister was suggesting a certain amount, but the budget, the Parliament refused. In fact, the Parliament decided to change what was proposed by the ministry. Basically, not specifically, not the matters that have to do with the SRHR or health-related issues. It was the matters that have to do with some administrative issues that have to do with the Ministry of Health. But in essence, in terms of the legal framework and some other activities, Parliament has the power to lay their hands on the budget. It is just that we didn't have capacity in the absence of the budget office. Even some other initiatives that Parliament did take with some consultants from the university and some other institutions in the past, they fell down because there was no guidance from the inside. Thank you very much.
Monsieur, are you satisfied?
I understand.
Okay. All right, thank you so much. In the interest of time, we will appreciate them again with a resounding hand of applause. And maybe only to also to emphasize that in our reporting also, let's consider the roles of our institutions, the key roles of Parliament, that of lawmaking, that of oversight, even budget approval, so that we see in our reports how Parliament is advocating maybe for an increase in the budget, how Parliament is following up through its oversight role. All right. All right, having said that, ladies and gentlemen, we shall break for lunch for about an hour. We shall be back here at exactly 2:10. All right, thank you.
Kaube, are there any tokens or they just walk in? Okay, you are free to go and have lunch. You're not hungry? There's a lot of food, yeah.
Miss, they should just put on their tax. You don't want to be charged for lunch. So make sure you have this tag which proves that you are one of us.
Researchers, please, 1 minute, just researchers. Let's come talk 2 minutes as you walk to lunch. Or you want to have lunch at 2 o'clock? Okay. Researchers, kindly approach.
So, oh, sorry, I was saying, I think SG has put in more detail what I was trying to raise during the plenary. When I said I don't quite hear the parliamentary dimension. I mean, let me give like a simplistic example. If, for example, you're saying we have not met the Abuja declaration target of 15% as parliament, but what have you done? Has there been a motion moved? Have questions been asked to try and get the executive to move to the 15% Abuja declaration target? So for me, that has been the missing dimension. What has Parliament done to get to those outcomes, that even the national outcomes that you are reflecting, but what has Parliament done for the country to get to those national outcomes? I think SG has put it in greater detail. That is what I was trying to raise.
Any minister of finance in Sweden receiving this impact from country A, they need to see that they've added value. Why did they fund a parliamentary probe? You are about accountability, you know, transparency. I've not heard anyone talk about corruption, leakage. I've not heard, but maybe it's in your report. You may find that it's not going to be a health committee raising these issues. This project is about governance. Yeah, governance. So let's reflect as we go along and see what we can do. Go back, and as you present, enhance. You have the data, but I guess you turn around your gaps, Zanele. You'll see what you would have done or could not have done, and indicate that the project, the value of this project in a parliament is going to be able to, yeah. Okay. Mm.
Good afternoon, colleagues. Good afternoon. Good afternoon. All right. SG, with your indulgence, we continue with the program with the minor adjustments that we communicated during lunch. So our next presentation will come from none other than Madagascar. So generally, let's try to marry these presentations to what Parliament does. Our key roles of lawmaking, representation, oversight, budget approval, ratification of international agreements as we contribute, right?
Madame le secrétaire général, Mesdames et Messieurs, distingués représentants des organisations partenaires de la SADC, c'est avec un profond sentiment de personnalité institutionnelle que je prends la parole pour vous présenter l'analyse des financements publics alloués du secteur de la santé et au programme de santé et droits sexuels reproductifs à Madagascar pour la période 2021 à 2025. Mon intervention se termine à la présentation, mais après mon intervention, mes deux collègues, Monsieur le directeur de la législation, Monsieur David et Madame Ida, chercheuses au niveau de la FPSADEC, qui continuent et à intervenir après observation et remarques après mon intervention. Cette présentation se divise en 7 sections. Tout d'abord, les objectifs de présentation. Cette présentation suit 3 objectifs principaux. Premièrement, analyser la place du secteur santé dans le budget général de l'État. En deuxième lieu, évaluer le niveau de financement des composantes spécifiques de la SDSR. Et troisièmement, identifier les trajectoires budgétaires et les risques de désengagement financier. Section A, l'évaluation des crédits affectés au ministère de la Santé. La première section est consacrée à l'évolution des crédits affectés au ministère de la Santé dans le budget général de l'État entre 2021 et 2025. L'objectif est d'observer l'évaluation de la part du secteur santé dans le budget national, ainsi que les tendances générales du financement tendance générale du financement public. Évolution du budget général. Ce graphique montre une augmentation progressive du budget général de l'État entre 2021 et 2024. Le budget national passe d'environ 2,44 milliards de dollars en 2021 à plus de 3,53 milliards de dollars en 2024. Une légère baisse apparaît ensuite en 2025. Cette évolution traduit une progression globale de ressources publiques de l'État sur la période. Part du budget santé dans le budget de l'État en pourcentage. En 2021, 6,4 par rapport au budget de l'État, le budget de la santé. En 2022, 7,71. En 2023, 2,22 milliards. En 2024, 6,81. En 2025, 7,53. Le niveau le plus élevé est observé en 2023 avec environ 8,22% du budget général de l'État. Par la suite, une diminution progressive apparaît jusqu'en 2025, où cette part descend à 6,40%. Cette tendance montre une baisse relative de la priorité budgétaire accordée au secteur santé. Cette décroissance inquiétante, malgré la croissance du budget de l'État, la santé perd du terrain en termes relatifs, traduisant une baisse des priorités budgétaires. Données budgétaires santé en 2021 et en 2025. Ce tableau résume les principales données budgétaires du secteur santé. Le budget du ministère de la Santé atteint son niveau le plus élevé en 2023 avec environ 286 millions de dollars américains. À partir de 2024, une diminution des crédits alloués au secteur santé est observée en 2025. Le budget santé descend environ 220 millions de dollars. Répartition du budget STSR 2023, 2024, 2025. Cette diapositive montre la répartition des financements STSR en 2023, 2024, 2025 durant 2025. Durant l'année 2023, par exemple, année les plus favorables, la santé maternelle totalise 6,79 millions de dollars, soit 2,38%, tandis que la planification familiale et la prévention VIH-IST restent toutes les deux inférieures à 1% du budget total. volatilité de la santé maternelle. La santé maternelle est la composante la plus financée de la STSR, mais aussi la plus instable entre 2023 et 2024. Son budget s'effondre de 6,79 millions de dollars à seulement 519 000 dollars, une contraction de plus de 92% en un seul exercice. Une légère reprise à 1,15 million est observée en 2025, mais le niveau de 2023 est loin d'être retrouvé. Cette chute brutale menace directement la qualité des soins obstétricaux et les objectifs de réduction de la mortalité maternelle dans tous les pays. Lacune budgétaire critique. Au-delà des rubriques identifiées, des domaines entiers de la STSR sont totalement absents des documents budgétaires officiels sur toute la période. Aucune ligne dédiée au service de la santé pour les adolescents. Aucun financement identifié pour les éducations complètes à la sexualité. La prévention des violences basées sur le genre demeure non financée. Les services de fertilité affichant un néant budgétaire sur 2023 à 2025. La traçabilité des produits SDSR et le suivi des investissements restent insuffisamment. Analyse globale et recommandations. De manière générale, les données montrent que le financement consacré au secteur santé et à la STSR reste limité. Plusieurs composantes importantes disposent de ressources fiables ou insuffisamment identifiées. Face à cette situation, il est impératif de renforcer durablement les allocations au secteur santé vers le seuil de 15% recommandé par la déclaration d'Abuja. Créer des lignes budgétaires spécifiques et traçables pour sa composante SDSR. Garantir un financement équitable et stable pour réduire la mortalité maternelle et couvrir les besoins non satisfaits. Réalisation concrète. Malgré des ressources limitées, certaines avancées ont été réalisées. Maintien des services de maternité, soins obstétricaux, planification familiale et prévention, VIH. Le gouvernement rapporte également 122 centres de santé de base construits, 13 hôpitaux achevés et 16 au cours. Des initiatives sur les BBG et l'autonomisation des filles ont été soutenues. Dette publique. La dette publique est passée de 7 498 milliards d'arrière en 2023 à plus de 232 milliards en 2025. Cette hausse réduit l'espace fiscal disponible et limite la capacité du pays au niveau davantage dans les secteurs sociaux, y compris la STSR. Pourcentage du budget national par rapport au PIB. En ce qui concerne le pourcentage du budget par rapport au PIB, la SDSR représente une part très faible de finances publiques. En 2023, environ de 0,20% du budget national. En 2024, seulement 0,015%. Et en 2025, environ de 0,03%. Cela montre que malgré les engagements pris, le financement des STSR reste marginal. Section C. Budgétisation sensible au genre et équité. Ce slide montre que la STSR à Madagascar est multisectorielle. Toutefois, les lignes budgétaires explicitement liées au genre sont principalement portées par le ministère de la Population. À ce jour, Madagascar ne dispose pas encore des mécanismes formels de budgétisation sensible au genre intégré dès l'élaboration de la loi de finances initiale. À Madagascar, la budgétisation sensible au genre est progressivement prise en compte à travers l'analyse des budgets sociaux et des travaux parlementaires. Cela a soutenu certaines interventions en faveur des femmes, adolescents et groupes vulnérables. Toutefois, l'institutionnalisation d'outils formels de budgétisation sensible au genre reste un défi. Quoi qu'il en soit, Madagascar, la budgétisation sensible au genre est progressivement prise en compte à travers l'analyse du budget social et aux travaux parlementaires. Maintenant, nous voyons voir la section E qui nous introduit au mariage d'enfants et engagement de Madagascar en matière de protection. À Madagascar, plusieurs interventions contribuent à la prévention du mariage des enfants, notamment à travers une ligne budgétaire dédiée à la protection de l'enfant, appuyée par une politique nationale de protection de l'enfant. D'autres actions passent par l'autonomisation des filles, la lutte contre les violences basées sur les genres, le maintien scolaire des filles et renforcement de l'état civil. Sur le plan législatif, Madagascar est actuellement en processus d'amendement de la loi sur le mariage civil afin de fixer clairement l'âge minimum du mariage à 18 ans sans exception. En parallèle, la loi type de la SADC sur l'éducation et éradication du mariage des enfants est également en cours de discussion au niveau des parlementaires. Section F va nous introduire à la question du contrôle de transparence et de participation. Le Parlement de Madagascar dispose de plusieurs mécanismes de contrôle, notamment l'examen budgétaire en commission, les débats en séance plénière, des questions adressées au gouvernement, ainsi que les consultations avec des parties prenantes. En matière de SDSR, ces mécanismes ont permis de soutenir des discussions sur la santé, le VIH, les violences basées sur le genre et la protection sociale. La participation citoyenne est également encouragée à travers des cadres de concertation, notamment le groupe de travail national sur la SDSR, qui réunit l'ensemble des parties prenantes concernées, y compris les ministères, partenaires, société civile, jeunes, experts techniques et partenaires. Madagascar, en ce qui concerne la section G, sur l'épreuve, données et reddition des comptes. Madagascar, à travers le Parlement et les acteurs concernés, s'appuie sur plusieurs sources de données pour l'analyse budgétaire relative à la SDSR, notamment les lois des finances, les données démographiques, les rapports sectoriels, les comptes nationaux de santé, ainsi que les données de partenaires techniques comme l'UNFPA, l'UNICEF, l'OMS et l'OSC. Toutefois, un défi majeur demeure l'accès aux données d'exécution budgétaire, en particulier dans le secteur de la santé. Reste encore difficile et qui limite une analyse complète et précise fondée sur des preuves. Section H. Cette dernière section permet à Madagascar de mettre en lumière les progrès réalisés au cours des derniers mois en matière de financement de la SDSR, tout en identifiant les engagements prioritaires et les appuis techniques nécessaires pour renforcer durablement les résultats lors des prochains cycles budgétaires. Engagement futur de Madagascar, la SDSR. Au cours des 12 derniers mois, Madagascar a renforcé le plaidoyer parlementaire en faveur de la SDSR, consolidé la coordination multisectorielle à travers le groupe de travail national et avancé sur certaines réformes législatives stratégiques. Pour les prochains cycles budgétaires, les priorités seront d'améliorer la visibilité des allocations SDSR, renforcer le financement des adolescents de la VBG et des groupes vulnérables, ainsi que promouvoir une budgétisation davantage fondée sur des preuves et sensible au genre. À cet effet, un appui technique en analyse budgétaire, suivi des financements et d'harmonisation avec les standards de la SADC sera essentiel. Merci pour l'attention. Pour la continuation à votre remarque et observations. Mes collègues, Monsieur le directeur de la législation et Madame Mida, vous répondront. Merci.
Thank you once again. I will start with Raj, of course. Your immediate reactions to the presentation, if you have any. Okay, I was saying your immediate reactions, sorry, to the presentation, if you have any.
Ouais. Je peux parler, madame? Ouais. Non, je voulais savoir pour Madagascar, hein, parce qu'il y avait une grande contribution des USAID au budget santé. Est-ce qu'avec les diminutions qu'on a eues en 2025, ça a affecté le budget général pour le pays Madagascar, surtout sur SDSR? Je voulais savoir ça. Merci.
Oui, merci beaucoup, Raj. Oui, justement, avec le départ de USAID, donc Madagascar fait face à des défis par rapport au VIH-Sida, par exemple. Et ce qu'on a fait, c'est que avec le nouveau gouvernement qui vient de s'installer et lors de la loi de finances initiale dernièrement, le ministère de Santé a pu bénéficier de 14 millions d'ariars de subventions, donc pour subvenir à tous ces besoins. Et également, cette année, en 2026, on vient d'établir une stratégie nationale, un nouveau plan stratégique national de lutte contre le VIH, où on est en train de faire des plaidoyers de haut niveau pour regrouper tous les financements possibles pour le riposte face au VIH-Sida, par exemple. Mais sinon, on est en train aussi d'impliquer le secteur privé pour que le secteur privé puisse appuyer tout le programme santé et surtout santé reproductive et droits sexuels.
Mr. Kurasha?
Je voudrais juste...
1 minute, Mr. Kurasha. Please proceed.
Oui, je voudrais juste ajouter quelque chose, si vous permettez. L'USAID, en effet, le fait qu'on a été exclu de l'USAID a eu un impact parce que le ministère de la Santé est le ministère le plus dépendant des financements extérieurs chez nous. Voilà, c'est-à-dire que 11% de ce budget-là est dédié au fonctionnement, alors que le reste est dédié aux investissements. Et c'est parmi ces investissements-là qu'il y a justement les apports extérieurs. Voilà. Donc, une fois que les apports extérieurs nous lâchent, forcément, il y a un impact sur le projet SDSR.
Mr. Kurasha?
Thank you very much, Chair. And good afternoon, Madam SG. Good afternoon, colleagues. I want to make 3 comments, and one of the comments that I'm going to make relates to the last point raised around external support for health budget or health financing. And I'm speaking not just to Madagascar, but possibly to all the colleagues that have presented or are going to present. Sitting where we are not at national level, at regional level, and within the context that we are, there are 3 things in my view that stand out when you look at focus on the role of Parliament within the context of the budget process. And it will be interesting to hear the reflections of colleagues in respect of those 3 aspects. The first one relates to risk.
risk that arises from the last point that was pointed out by the colleague, where the funding is skewed in terms of over-dependence on external funding. The reality is that in the immediate to medium term, it looks like we are going to be on our own, particularly in the SADC region, where part of some of the interventions that have come through would have been unpalatable for the reasons that we know. So the immediate question that one wants to ask is, are there any active efforts to focus on domestic resource mobilization? And has Parliament been visible in any of those efforts? Because that speaks really to the question of resilience and to the question of sustainability. So it would be good if that question come up in terms of spotlighting Parliament, as the other colleagues have highlighted earlier. The second and possibly more fundamental question relates to the whole issue of parliamentary oversight and accountability. Because it's good to hear the narrative in terms of what is being allocated, but tracking becomes more important, including in terms of following up on audits. It would also be important to hear what parliaments have been doing and whether there are sufficient capacities, how this is distributed, whether this is happening at budget committee level or it's decentralized within the portfolio committees that oversee the different sectoral ministries and agencies. The last one possibly linked to the one on oversight, because that also speaks to issues of corruption when talk about accountability. Sometimes oversight is nominal and not substantive for different reasons. Are we able to say parliaments have been able to shake off the barriers, the obstacles, and they are demonstrating that capacity to distill and be able to track in line with the oversight function of Parliament to ensure there is accountability. Then the third and last relates to issues of efficiency and value for money. When allocations have been done in the manner that has been characterized, and we have tracked expenditure, we have looked at the audit's outcomes, the question to ask is really the impact per dollar invested. And I think Parliament sits as the institution that must help us to respond to that question. And I'm just keen to know how that is playing out in terms of your experience, your practical experience. Like I said, I'm just imagining when I look at the context from outside when I'm not inside a national parliament. Thank you, Chair.
Thank you, Mr. Kurasha, for those points. South Africa.
Thank you for the presentation. I just had a few questions. And the one has to do with the slide you just moved from, which is the share of health in the state budget. And I just wanted to get insight into what's happening there, because there seems to be quite a large, not large, but variations, right? So you went from 6.4% of total budgets to now 7, what was the last number? I think it was 7 point so. But to say, when, to maybe explain to us what is happening there. Is it because more money is going towards debt servicing costs? Is it because more money is going towards other programs? But also, how does the Department of Health plan when the share of budget is continuously changing? I think maybe just to provide context on that. And also then to also ask about, you spoke about how the debt as a quantum is increasing. But to maybe share with us what is happening to the debt to GDP ratio itself and maybe what's happening to debt servicing costs, because it could be growing as a quantum, but your economic growth could be high, therefore debt to GDP is actually not necessarily increasing, or, you know, the debt servicing costs are not that. Yeah, so just more clarity on those points.
I'll allow the presenter to respond.
Merci de m'avoir donné la parole. Donc, sur le budget, la première question était le mode de planification du budget au niveau du ministère de la Santé publique, si j'avais bien compris la question. Eh ben, comme je vous avais dit, c'est un ministère qui dépend beaucoup des financements extérieurs. Donc, au moment où on planifie des budgets, on établit au niveau de l'exécutif des priorités. Si ces priorités-là sont financées par les bailleurs de fonds, en l'occurrence, le programme se tient. Si ce n'est pas le cas, il est laissé en l'état. Il y a aussi un fait, parce que vous avez suivi les actualités, ça dépend aussi du contexte politique que nous vivons. Voilà. Donc, dans le contexte politique actuel, la priorité, par exemple, est axée sur le domaine de l'énergie et de l'eau. Voilà. Donc, la plupart des allocations budgétaires vont être affectées au niveau de ces choses-là. Voilà. C'est pour ça que ce budget-là est fluctuant comme ça. Et du fait aussi qu'il n'y a pas de rubrique fixe définie, il est fortement tributaire des aléas justement internationaux. Voilà. La deuxième question était, est-ce que vous pouvez répéter votre deuxième question, s'il vous plaît? Alors, il convient de rappeler que pour nous, donc le budget national, il est déficitaire chaque année à hauteur de 5%. Et ces 5%-là sont comblés justement par la dette. Voilà. Donc, notre pays, soit, donc pour combler ça, il faut qu'ils augmentent le PIB, il faut qu'ils créent des richesses, soit il faut l'aider beaucoup en termes d'allocation. Et ça, ça ne date pas d'aujourd'hui, ça date déjà de plusieurs années. Et voilà. Donc, en fonction des besoins de la population et en fonction aussi de ce que nous demandons, cette dette aura tendance à augmenter. Et ce sont des dettes prévues et qui ne sont pas compréhensibles parce qu'ils sont déjà déterminés à l'avance quand on le demande. Voilà. Je ne sais pas si j'ai compris. Voilà. C'est bon? Continue.
J'aimerais juste intervenir par rapport aux remarques que Kouracha a fait tout à l'heure. En fait, comment est-ce qu'on procède au sein du Parlement? Donc, comme tous les parlements, on travaille beaucoup avec les commissions. Pour Madagascar particulièrement, on travaille avec 5 commissions particulières, voire 6. Commission santé, commission de l'éducation nationale, commission finances, commission jeunesse et commission de genre également, et commission de l'éducation. Et à travers ces commissions, donc, c'est avec les commissions qu'on fait travail pour tout ce qui est plaidoyer et lobbying. Et également, ce qu'on a établi au sein du Parlement de Madagascar, c'est qu'on a regroupé tous les parlementaires engagés et en faveur de la SDSR dans un réseau qu'on a appelé Réseau parlementaire pour la justice reproductive. Et c'est surtout avec ces parlementaires qu'on travaille pour les outreach, les visites communautaires, et pour on prépare les motions et les questions pendant les débats avec les exécutifs également. Et c'est à travers ce réseau qui est vraiment très engagé pour tout ce qui est genre et SDSR qu'on travaille. Je ne sais pas si j'ai pu répondre aux remarques. Merci.
Mr. Kouracha, have you been answered? SG, then my fellow colleague, and we wrap it up.
Well, thank you very much, Madagascar, and all other colleagues. Just to say that these questions are taking us back to the theory of change for the project. And I think what colleagues are asking is critical to deepen your own ecosystems analysis. What is happening in your country? So, I mean, this analysis should not appear to be coming from without. There's a context that colleagues are helping you locate in your preambles or introductions to your presentations so that we may better appreciate. You have the data there, the questions are being asked. You have the data around domestic financing, you are indicating the gaps, you are indicating the areas which you are focusing on. But perhaps it may help you to go to the theory of change. And Ronald, kindly distribute the PowerPoint for the project to assist other colleagues that don't have it. When you look at the output, for instance, I just want to read it out to you so that you can also locate why these questions keep coming, why the likes of Raj and Gurasha keep asking you know, some questions which may appear broad, just to refine improvement as we go along, and those that have not yet come on board to be able to do so. The output that was identified, there are many, but particularly to the one related to budget. It says members of parliament demonstrate a heightened interest to advocate and interrogate for increased SRHR budgets through the yearly budget process, leading to advanced predictability, sustainability, and innovation in SRHR expenditure. There are others that can also be, looked at from mechanisms among others. But when you look at the corresponding outcome, parliaments consistently vote for enhanced SRHR budgets, which promote the delivery of universal SRHR services, implement SDGs 3 and 5, and promote gender-responsive budgeting and universal health coverage. UHC is there, hidden in most of your presentations. But I think what we would like to hear is the pride that which you took to be deliberate in ensuring that at least we can either see through analysis that there is a trend and be able to be, to admit at the parliamentary level that we could have infused the following, or we want to continue to infuse the following for whatever it is. And it goes further. When you look at the impact, we're looking for that visibility of members of parliament. You know, it's very clear. It talks about they're visible, they're present, you know, and therefore responsive. And ultimately, when you look at the vision, it then comes to all the issues you are raising. Are we dealing with SGBV? Are we dealing with this? Are we dealing with this, among others? And I think when you all present, we appreciate that in any analysis that has been done at the regional level related to domestic financing of member states or whatever it is, there are also categories of countries at where they're at. Middle income countries, and in the innovation that then seems to have followed in that regard. So we already have the best practices in terms of what then can be done. Did parliaments take advantage of taxation? Did they take advantage of this, and that? Did they improve policy environment, among others? So please bring us back there as you present or as you improve on your. And I was looking at a case study, the case study that was done some time back. Some of the countries at that time were said to be stable and meeting the needs. The likes of Lesotho, and now Madagascar and others were in another category. So the question that says, what is really happening there, I think is quite important. And it went further to look at out of pocket, look at whether UHC indicators are met, among others. So I'm just encouraging you that just be a little bit brave to make these linkages. We don't want to only hear the good side of it. We want to know what we can reinvent or innovate for parliaments to take part in these processes. So I think I would like to put it out there. And if you, even as you present and that comes to mind, integrate it in your presentation. I hope that helps us.
I cannot say it better. Thank you so much, SG. We proceed with the last contributions from my colleague.
Thank you. I think SG has clarified a lot of issues, which I wanted to talk about as well. But just to say something about domestic resource mobilization that Kurasha talked about. I think that most of the countries suffered, setback when donor support was withdrawn from these countries. However, most of the countries came up with, domestic initiatives. One, some of the countries increased their taxes, but others broadened the tax. You increase the taxes, broaden the tax. And the challenge that we have in most of these countries is that resources to certain areas, SR, HR are being deprived because of the pulling out of the donor community. I also wanted to talk about the citizen participation, which I saw in my, our colleagues have mentioned. I don't know to what extent citizen participation is embedded in the law. In some countries, it's in the law, it's actually in the constitution. So the National Assembly or parliaments have enacted law to ensure that the citizen participation at every stage of the budget process. And I think that's also very critical because if we are talking citizen participation, sometimes in the past you find that governments will choose to consult or not consult. But if it's in the law, the follow through is very critical because then they are compelled by the law. I just wanted to talk about the issue of the dedicated budget line on the child protection. I was thinking, is this in one ministry? Is it sitting in one ministry? Or it's going through, or it cutters across different ministries? Because if you have a dedicated budget line, then it should cutter, either sit in one ministry, but that one ministry may not cover the SR/HR because of the cross-cutting nature of the budget. Thank you.
Thank you. I think they must respond to the last part of the question. Yeah.
Par rapport à la participation citoyenne, je vais intervenir sur le fait que, comme la plupart des pays en Afrique, cette participation n'est pas très ouverte en ce qui concerne le budget. Donc, c'est très limité. C'est très, très limité. Et pour Madagascar particulièrement, pendant les travaux de commission, donc les organisations de la société civile peuvent intervenir, mais jusque-là, il n'y a pas de données ouvertes pour que les citoyens puissent vraiment être inclus et participer en ce qui concerne le budget. Et pour la dernière question, c'est comment ça se passe la ligne budgétaire dédiée à la protection de l'enfance. Pour Madagascar particulièrement, nous avons un ministère de la population solidarité qui est dédié également à la protection de la femme et de l'enfance. Et c'est avec ce ministère qu'on a cette ligne budgétaire. Et comme vous avez dit, ça pourrait ne pas intégrer la question de SDSR, mais ce que Madagascar, avec le groupe de travail national du projet, a intégré la direction, le ministère, pour que cette ligne puisse considérer tout ce qui est travail, mariage d'enfants, par exemple, lutte contre le travail des enfants. Et donc, cette ligne avec laquelle les parlementaires ont participé pour la politique nationale de protection de l'enfance considère également tout ce qui est lutte contre le mariage d'enfants, également tout ce qui est lutte contre le travail des enfants et la considération des adolescents et des enfants. Je ne sais pas si je peux lire.
Thank you so much. Let's appreciate Madagascar. In the interest of time, we proceed to receive presentations from Malawi. Please take note of the observations made by the SG. Ladies and gentlemen, these are ladies. Let us appreciate them as they walk through.
This works. Thank you very much. Director of Ceremonies, Madam SG, colleagues, good afternoon. My humble duty this afternoon is to actually paint a picture, I'll say, before my colleague comes in with the actual SR, HR budget, and indeed the role of Parliament in influencing this. I'm painting a picture of our economy. Quite brief. I'll be straight to the point, but maybe for us to even understand what actually entails, like when we're actually coming up with, when the ministry is coming up with all these figures and ABCD, we need to understand the full picture. The sentiments on the floor, especially from Madam SG, are quite clear. We understand this project wants to see the influence of Parliament in this subject matter. I can assure you, we'll try to actually touch on that in our presentation, but I can assure you, Madam SG, even in our main report, we have Hansard snapshots of members of Parliament speaking to this. So that's something you'll be able to appreciate. Thank you, thank you. So, okay, in terms of presentation outline, I'm painting a picture. It's not a rosy picture, unfortunately, as is the picture in all of our fiscus, I believe, unless maybe we have a country in this room which has ever achieved a balanced budget. We've never. Maybe our colleagues are doing better. Oh, South Africa. No, South Africa doesn't count. South Africa doesn't count. But the picture is never rosy. So I'll walk you through an overview of Malawi's fiscal position, the macro fiscal constraints we face, which actually essentially affect health sector allocation, and indeed SRH by extension. And I'll walk you through now the general health sector allocation. My colleague will walk us through the SRHR and indeed the role of Parliament. Like I've already mentioned, for us to appreciate, to understand the subject matter, to appreciate it, we need to look at this in a broader perspective of some sort. SRHR in Malawi, and of course all countries, must be understood within a context of several constraints we face. In our case, we face persistent fiscal deficits. We have high public debt, which keeps rising year in, year out. And indeed, we have limited domestic resource mobilization. Now to take you back, this is our budget, as it were. We're working with, in this current financial year, we're working with an expenditure of, that's 10.978 trillion Malawian kwacha, which is about 6.33 billion US dollars. And all that is against a revenue of 4.68 billion US dollars. Already we're working with a gap. How do we finance that gap? That's where the debt issue comes in. We all know this. And again, on the same macro fiscal challenges. So our debt, our deficit, which is currently at, this should be 1.64 billion US dollars. That's our current deficit, is actually way above the SADC recommended threshold of 3% of GDP. We are working with 9% of GDP fiscal deficit. It's a slight improvement from the previous financial year, which when we had an 11.9% fiscal deficit GDP ratio. We're working with 9, which is still way above the 3%. That's what we're working with. How do we finance this deficit? We borrow. Where do we borrow? Unfortunately, in our country, we borrow more domestically than we do externally. And we all know this also. Domestically, higher rates than external borrowing. Now, this is also a very interesting picture. I'm painting a picture, which, like I said, it's not a rosy picture, but this is also interesting. We're talking about domestic resources. This is a compressed budget framework. We have a situation in our country where our domestic resources are not able to finance the budget. We all know this, yes. But even those domestic resources are not able to finance the statutory obligations. This is unfortunate. We're talking about the debt. We're talking about the wage bill. We're talking about the presidency. We're talking about all these statutory obligations. So as a country, in this current financial year, Our domestic revenues are pegged at 3.72 billion US dollars. But our statutory obligations alone, just statutory, are at 3.45 billion. In the previous year, they were not even enough. The domestic revenue was not enough even for the statutory. This time around, it's like slightly, we've made it. 3.72 billion versus 3.4 billion US dollars. That's just statutory. So now, before we even talk about the social sectors, before we start talking about health, education, before we even talk about the productive sectors, we need to first pay our statutory obligations. And our domestic resources are not able to afford that. Now, moving on to the actual health sector allocation. Indeed, the health sector allocation has been increasing steadily over the years. We had 741 billion Malawian kwacha in the previous financial year. Now we're working with 1 trillion Malawian kwacha. It's an increase, but is that actually even enough to reach the 15% we keep talking about? The answer is no. We rose from 8.7% of the national budget in 2023-2024 to 12.2% of the budget. Now, this is also interesting. Why that jump? Was it a good thing? Oh, no, actually, health sector has actually received this. Is this actually going towards the health sector and the programs we're even talking about here, like programs like that? That's the question. In our case, that jump was due to, we had in this particular year, the Ministry of Water and Sanitation, which was a standalone ministry before, it was added towards health. So on paper, it's a jump. We can celebrate. We've moved from 8.7% to 12.2%, but no, it's only because we've combined two ministries. And then there's a decline, which could be worrisome. We can sit in this room like there's a decline. No, the decline is also in account on, now the following year, the Ministry of Water and Sanitation was removed from the health sector. So now there's a decline, which brings actually this idea of the program-based budget we talked about at some point. Now we're able to actually maybe pinpoint, is this actually going towards like the interventions within health? And is that going towards SRHR? We need to be able to trace all this. But overall, the picture is we've still failed to reach the 15% over the years. And breaking it down to per capita, this allocation of 1.2 trillion Malawian kwacha, which represents 9.3% of the national budget, translates to a per capita allocation of approximately 25 to 26 US dollars. And this is still way below the recommended threshold of 76 US dollars per capita. I would actually, that's a picture I wanted to paint, and I would like to stop here to allow my colleague to actually walk us through the actual SRHR and indeed give you even snapshots of the interventions in Parliament. Thank you.
I'm in my church. Okay. When I'm in my church, when the pastor says, it's good to be here, we respond, it's wonderful to be here. So we can also do the same. It's good to be here. It's wonderful to be here. It's good, good. It's wow. It's wow. Thank you so much. Allow me to ride on the protocols that have been already established. My name is Gomesiani Ngwira. I'm the SRHR project, SRHR research officer attached to the Parliament of Malawi. So my task this afternoon is just to present sexual reproductive health rights budget mainstreaming in Malawi. How are we faring? How is the trend like? So just like in any other countries in the SADC region, there's no specific SRHR budget line. We can't see SRHR as SRHR budget proper in the budget document. This is because SRHR is broad and it is embedded in different sectors. For example, we have Ministry of Health, under Ministry of Health, we have youth-friendly health services, we have family planning, we have maternity, maternal issues, and many more. But also we have SRHR under Ministry of Gender, issues to do with child marriages, child protection, and many more. We also have SRHR in the Ministry of Education. Comprehensive sexuality education, it's under Ministry of Education. Back to school issues, they're under Ministry of Education. So in terms of identification of sexual reproductive health rights budget, we usually identify the sub-budget lines from the program-based budget, but also from the departments in the ministries. For example, in Malawi, we have under the Ministry of Health, we have the Reproductive Health Department or Directorate. They have their own budget lines for SRHR. We also have the HIV and AIDS department. They have their own budget lines. So if we engage them, they're able to tell. Under family planning, in this year, we were allocated also. Under youth-friendly health services, we are allocated also. That's how we are tracking SRHR budget in Malawi. So as you can see from the graph, that's how, this is some of the programs that we have managed to track or identify from the line ministries. And these are some of the programs that our members of parliament are doing their oversight on, but also they also lobby for funding. Just for an example, for family planning, ever since we started the project, we have seen a progressive increase after our members of parliament engage with the treasury to lobby for an increase. And we have seen a reduction in the maternal mortality rate. This is how we are trending. And for family planning, in 2026, 2024, 2025, we're at 700 million Malawi kwacha, and we rose to 770 Malawi kwacha, and we are now at 1 billion Malawi kwacha. And for youth-friendly health services, this is a budget line that we just lobbied with the members of parliament to at least Malawi to have, to establish a budget line for youth-friendly health services so that our young people are being taken care of. So we have seen also an increase in budget line for youth-friendly health services. And on gender-based violence, we also have a budget line. Unfortunately, the Ministry of Gender is the least funded ministry in our country. We don't know why. We had to find out. Maybe because it is issues to do with gender, they are embedded in all the sectors in Malawi. Maybe that's why they receive. But we also saw an increase in 2025, 2026, but now we have seen a reduction. However, our members of parliament have been able to lobby for an increase. I'll show you one member of parliament talking about this in our parliament. In terms of estimated quantum of sexual reproductive health rights, it's difficult to report on the estimated quantum. Why? Because we don't have a specific budget line. However, UN agencies, CSOs, and also the SRHR project, we have been able to come up with 3 strategies or 3 ways that helped us to come up with estimated quantum for sexual reproductive health rights funds. So the first way, normally Parliament of Malawi allocates 5 to 15% of the health budget to sexual reproductive health right issues, programs. So the first way to find the quantum is just to find the 5% of the health budget and also 15% of the health budget, that year's health budget, and then we find the average. We just add the percentage and then divide by 2. That's the average quantum of SRHR. The second way is to go into the program-based budget and identify all the SRHR-related budgets, and we add them and we find the quantum. The third way is to identify SRHR programs in the health budget, health vote. So the health vote has got SRHR, has got programs where SRHR is embedded. So that's how we also find SRHR quantum. Just like, for example, for the 2026-2027 budget, we managed to find the SRHR quantum in US dollars. We managed to add the allocations on the programs where SRHR is embedded. For example, the medicine budgets include family planning and maternal commodities. That was allocated 38 million US dollars. And from the allocation for central plus district hospitals plus equipment, the allocation was 23 million US dollars. Allocation for ARVs plus blood, it is in there. All these allocations are in the health budget. ARVs plus blood, this is where you can find HIV and AIDS and SRHR services, and it was allocated 7 million. In total, it came up to 68 million US dollars. That's the quantum for 2026-2027 budget. So for the past 3 years, this is how it is in Malawi, the estimated quantum for SRHR. So as you can see, 2024-2025, it was 554 million US dollars. 2025-2026, it was 50 million US dollars, estimated quantum for SRHR budget. 2026-2027, $68 million. So at least we are picking up. Percentage of sexual reproductive health right budget with respect to total budget and percentage to GDP. So actually, Malawi spent 3% of the GDP on public health, where SRHR is embedded. And this is far below the World Health Organization's. So World Health Organization recommends 5% of the GDP on to allocate the countries should allocate 5% of the GDP to the public health, but now we're at 3% as a country. Like for 2027, 2028, 2026, 2027, roughly government allocated 68 million US dollars on SRHR, and this is only 11.5% of the health budget for the 2026-2027, and 1.05% of the total national budget. So Malawi in 2026-2027 has allocated only 1% of the total budget to the sexual reproductive health programs. In terms of how we are faring for the past 3 years, as you can see, for the 2024-2025 budget, it was only 1% of the total budget, 1.5% allocated towards sexual reproductive health rights. In 2025-2026, it was only 1%. So we are around 1% of the total national budget being allocated to sexual reproductive health rights programs. The sufficiency of the sexual reproductive health rights programs. As a country, Malawi, our SRHR budgets are not sufficient enough, and they have never been sufficient. Why are we saying so? If we are looking at the GDP, percentage of the GDP and the international benchmarks, so we already said, as I've already said, that Malawi allocates only 3% of the GDP on public health. This is where SRHR is embedded. But also, if we consider the 15% Abuja declaration, we are still too far. The second reason why we are saying it is sufficient, youth sexual reproductive health rights needs. currently Malawi, the Malawi Demographic Health Survey has reported an increase in the teenage pregnancies despite all the efforts. We were at 29%, but now we are at 32%. It means that young people, there is still a gap. There is a gap. We are not meeting the needs of our young people in as far as sexual reproductive health rights is concerned. But also we are saying that the SRHR budget is not sufficient because of the costs versus what is available in Malawi. So UNFPA recommends that every country should be able to allocate $25 per woman, aged between 15 to 49, to achieve the full essential SRHR package. So currently in Malawi, we have 5.5 million women who are aged between 15 to 49. It means we need $137.5 million per year to achieve full essential SRHR package. What do we have currently? The identifiable SRHR quantum is $68 million for the 2026-2027 budget. Donors, when they come in, they contribute 30 to 40 million towards sexual reproductive health rights programs. The total is 100 to 100 million That's what we have in Malawi. This means that for us to reach the UNFPA recommended package, the figure, 137.5 million, there's a gap, 30 to 37 million So our budget is still not sufficient. I hope I'm making sense. Okay, from the budget that is being allocated towards sexual reproductive health rights, oral health in general, what have we seen as successes in Malawi? So, as I've rightly put it, we have a new budget line for youth-friendly health services, and we have seen that Malawi has scaling up the youth-friendly health service provision or the health facilities that are providing youth-friendly health services. So for a health facility to qualify as a youth-friendly health service, there's a checklist that the ministry uses. The health workers have to be trained on youth-friendly health services. The infrastructures have to be youth-friendly. So with those finances, the Ministry of Health is able to scale up the youth-friendly health services. We are now at 75%. It means 75% of the health facilities are now youth-friendly, where young people can comfortably go and access the youth-friendly health services. We have seen also Ministry of Health scaling up of outreach services. Through the funds allocated, they are organizing outreach services where they are able to reach out to young people in the outreach locations. And we have also seen infrastructures being upgraded in one of the districts. Ministry of Health has managed to renovate family planning rooms in the 8 districts, in the 8 health centers in one of the districts. And we have also seen completion of the construction of National Cancer Center. And in our country, we didn't have radiotherapy, whereby women with cervical cancers were not able to receive the services. They were just dying. Some, those that have money, they could go to other countries to access the radiotherapy services. But now we are able to provide the services. So for the 2025-2026 budget, we saw the Minister of Finance allocating funds towards construction of 55 health facilities to improve on accessibility, including the maternity services. Parliament influence on budget. Yeah, for Malawi, we have seen members of Parliament influencing budget. at each and every phase of the budget cycle. I'll give you like an example. During budget formulation, there are consultations that are made. So the minister also consults members of parliament for their input. But before the consultations, under the project, we have been inviting the line ministries, more especially the departments that have SRHR programs, to present what was provided in the previous budget. Was it sufficient? How did they spend it? And how much are they requesting from the treasury? So from there, when the members of parliament are consulted, it's when they contribute to the minister to say, we need family planning, we need an increase on family planning budget because of social reasons. So that's how members of parliament are contributing. But also even on oversight, the audit phase, we have seen members of parliament, actually in our parliament, we do have the quarterly committee meetings where our members of parliament, they summon their line ministries for them to present how they are using the funds. Is there timely disbursement of funds from the treasury? If there are gaps, how can parliament assist to help you so that you are able to implement the services without challenges? So throughout the budget cycle, our members of parliament are able to influence, but also in our parliament, in the chamber, members of parliament are also contributing through presentation of report recommendations, but also through motions, through questions, and many more. Just as you can see from the slide, this was presented on. It was a report being presented by the chair for the health committee after scrutinization. After the minister had presented the budget, our members of parliament, they go into cluster committees where they scrutinize the budget and they come back and make contribution. So this is one of the contributions that was made by our member of parliament. This is on domestic resource mobilization. We are equally hit by the shrinking of the donor funding. So our members of parliament are lobbying for domestic resource mobilization, as you can see. I hope you are able to read. I'll not read. So these are some of the recommendations from the Committee on Health. Introduction of toll gates in borders so that we can make a lot of money that will contribute on our health sector.
Mr. Jenje,
This is
you may
another
want to just read
parliament influence
bottom.
on gender.
verbatim what the honorable member said.
Okay. On domestic resource mobilization, one of the chairperson of the Parliamentary Committee on Health said, Mr. First Deputy Speaker, sir, we are all witnesses to the donor flight and fatigue. Our budget support has been shrinking. However, how can I remove this? It's blocking me, this one. The talking is blocking me. Okay. So I said, Mr. Speaker, Mr. First Deputy Speaker, sir, we are all witnesses to the donor flight and fatigue. Our budget support has been shrinking. However, we are very slow to act with urgency to the donor flight. We continue doing business as usual. Mr. First Deputy Speaker, sir, this cluster committee suggests introduction of some taxes on products such as tobacco, sugar, and even alcohol. The cluster committee further suggests that the introduction of toll gates in border district for revenue generation. That was Honorable Chairperson of the Committee on Health. I can also give an example, another influence on gender. The Committee on Social and Community Affairs noted that there's a reduction on budget allocation towards the Ministry of Gender. So this is what the chairperson said. Mr. First Deputy Speaker, sir, the cluster committee notes with serious concern that the allocation to the Ministry of Gender has declined from 69.6 billion in the 2025-2026 financial year to 47 billion in the 2026-2027 financial year, representing a reduction of approximately 32%. This substantial reduction is likely to adversely affect the delivery of essential services to vulnerable populations. Mr. First Deputy Speaker, sir, therefore, the cluster committee urges government to reconsider the reduction in the ministry's allocation, prioritize funding for social protection programs, reinstate funding for elderly services, and allocate 850 million kwacha to the National Children's Commission. That was Honorable Saville Kafafa, chairperson of the Committee on Social, but also on influence on 15% Abuja target. This is what the chairperson for the Committee on Health said. Mr. First Deputy Speaker, sir, the committee observed that the health sector budget rose by 24% from 630 billion in the 2025-2026 financial year to 783 billion in the 2026-27 financial year. Yet, the 9.3% allocation of the national budget towards the health sector falls short of the 15% in as far as Abuja Declaration is concerned. Mr. First Deputy Speaker, sir, the CASA Center needs at least 80 billion per year, but only 15.9 billion was allocated. Teenage pregnancies continue to rise with the adolescent birth rate increasing from 28% to 32%. In rural areas, Mr. First Deputy Speaker, stories of teenage pregnancies and child marriages are mind-boggling. The figures are so obscene. The birth rates exceed 40%, exacerbated mainly by cultural practices, poverty, and myths about contraceptives. That was Honorable Chairperson of the Parliamentary Committee on Health. But there is also an influence on the gender responsive budgeting. I think, Leonard, you can play the video. I can promise that. It's there. I'm down.
She deserves another round of applause. I think they did well. I'll now open the floor for a few questions so that we at least finish by 4:30, 4:45. We still have a number of presentations that are yet to be done. So a few observations from the floor. I'll start with any observations, ladies and gentlemen. There is Lesotho over there. Anyone else? Botswana, Mr. Kurasha. let's be pointed in our contributions, isn't it? All right, Lesotho, then Zimbabwe last.
Your mic is green. No, you are not audible.
Okay. Yes, I was saying, I would like to thank her for a very beautiful presentation indeed. But I have just one question for her. I see the motions written by the chairpersons of committees to the Speaker of the National Assembly, trying to show the influence from committees responsible for issues of health or SRHR. My question is it only enough to have such motions? Or what is the level of implementation? Is there a follow-up after the motions? What was the end result? Having written such motions, what's your take? Because my issue is we could write these motions, the Speaker could read the motion, but ultimately nothing happens. Can we really say the committees had influence on the oversight or accountability? So if you know, what was the end result for the motions? Yes.
Let's move to the next one.
Yes, connected to that one, there's a slide where you shared successes, but before then, thank you very much for the enlightening presentation. So you had a slide where you showed us the successes. So what I wanted to find out was the extent to which the successes are attributable to the SADC PF funded project. To what extent can we say the country did this as a result of what we did as a project? Thank you.
Thank you very much. My question will link with the last two presentations, but I want to go back a bit to say what Malawi did, which we may not necessarily have seen in the other presentations, was the intentionality of placing parliaments as the subject. So for me, you can't even begin to talk about what may have happened after if the story is not about parliament. So that for me is, it takes a different dimension when we are able to see what parliaments are doing in action in those. So even where you may attribute or create a relationship between what the project has contributed to whatever outcome, at least you have let us in terms of where is parliament. So when you say we resorted to, or the member states government resorted to taxes in the face of declining budgets, external budget support for health, was this happening with no parliament somewhere in the play? So that is upon yourselves to demonstrate, because that speaks to the theory of change of the project, as the Secretary General said. So for me, I therefore want to almost say like what Simeon in the Bible said, let thy servant depart in peace. Because for once, the subject is about parliament. Otherwise, sometimes if you were passing by when presentations were being made, you will understand that it's about country X, but you never tell whether this was being presented by the Judiciary, Minister of Finance, or so we had this in Parliament at one point where questions such as the one that was asked by the member after being presented, the minister responds. The media would come and report what the minister said in response without saying, actually, it emanated from the member of parliament who asked this question. And the onus is on you to change that and put parliament as the subject. Showcase what you are doing, because we know there is work you are doing, but it wasn't quite coming out. And I almost feel like want to lift you up into the skies, Gome. Thank you very much.
Thank you. Thank you, Gome, for the presentation. It was quite informative. I just want a comment from the facilitator around the meeting the Abuja Declaration. Quite often we have responses such as that 15% for youth, and if you consider the Maputo Declaration for the agriculture and the education, then it becomes the 2020, then 45%. Then you have 45% of the budget allocated to 3 sectors, and what then happens to the rest of the sectors as a reason that is put forward to say we can't then meet these declarations that are made at either the regional or the international fora. So I just want to your comment around this response. Thank you.
Yes, thank you, moderator. I just noticed that for starters, my colleague who started the presentation painted some sort of gloomy picture about the fiscal deficit, 11.9% of GDP. And perhaps that's not even the outstanding. The outstanding could be worse than that. I think I'm coming from a country where we such challenges, and they're working towards 9 point something percent GDP. And going forward, you will see a trend that apart from the statutory obligations, they're basically borrowing to finance the budget. And that becomes a challenge in my view, and it will be interesting to see how that is going through in terms of implementation of the budget, and particularly the budget for SRHR. The issue of approving the budget, I know that in different countries, different committees provide oversight on a particular ministry. I know for a fact, for instance, that the ministry, the Committee on Agriculture should be able to provide oversight on the Ministry of Agriculture. And I think that's a trend in most of the parliaments. I'm getting curious, what happens at approval? There's oversight, but there's also approving the budget. Do these committees, and I noticed or I heard that they started talking about cluster committees. How do those relate with committees? How are the cluster committees coming into the picture? I think it would be interesting to know whether this is helping in terms of approving the budget for SRHR going forward. Thank you so much.
Thank you. You may proceed to respond.
Thanks so much. I think for the first question, Kurash has rescued me, but I just have to say something on that one. End result on the motions. Normally, we have immediate, intermediate, and long-term results. So when you want to see an impact, we start with lobbying. So this is what members of parliament are doing. They start with lobbying, giving them recommendations, and then we monitor. After the member of parliament gave recommendations on maybe introduction of taxes to promote domestic resource mobilization. What is now what has the Minister of Finance done? So in the next, the mid-year review budget, we assess to say, did the minister respond to that recommendation or not? So we assess on the impact as time goes. Number two, successes. Are the successes attributable to the SADC-PF project? Yes. When I was presenting, I presented something on the progressive increase on family planning budget. That's what, as a project, we have been doing. We have been working with members of parliament, the technical working group. We also have the reproductive health directorate in our technical working group. So that was their main challenge on budget allocation on family planning. So we have been organizing different engagements with our members of parliament, with the treasury, just to make them understand that increasing our budget allocation on family planning is very, very important. That's why we have seen a progressive increase. But also on the development, introduction of the sub-budget line for youth-friendly FSFCs. We have been engaging with the young people and also the Ministry of Health to lobby with the Treasury so that they introduce a budget line for youth-friendly FSFCs. That's why we see the budget through the project. Comment on 15% Abuja Declaration. There's a belief, we believe that as the budget increases, it also have a positive impact on the allocation of SRHR. That's why we also continue lobbying for 15% Abuja Declaration, because we want more funding towards the healthy, more funding towards sexual reproductive affairs. I hope I've made myself okay. I don't know. So my colleague will take the last one. Okay.
Thank you so much, Gomez. Let me join everybody else to congratulate Malawi as well. The issue of attribution is quite important for us to really, as we attribute, as we indicate how this led to what, to really ensure that we have some of that evidence readily available. In this instance, I was just wondering, because there was a time, I think it's 2 months ago, if not this month, I got an article from Sweden, and they said, look at this. It was another organization in the technical working group which reported and published what they've been doing with Parliament. And they were showing, can you explain that if you've seen that article? I think it was it Kerr or somebody who wrote an article to show how they are working with parliaments to mobilize resources for the budget. So if players in that context of the technical can also see the level of effort, and at that time they had also requested for resources to follow through and make sure that they don't lose track of this level of effort that has been registered in Malawi. So I think I'm just saying this to say that you can never be alone, and you are not the only players. The architecture of the project is very, very clear. If you cannot attribute yourself because you don't speak in Parliament, there are other avenues and other players that influence Parliament. And if they can also tell the story, then you've done what the theory, the ideology of the project is about. So I think I just wanted to add that in, because it didn't come from the project. Before Gomez reported, somebody had picked it online from Sweden and sent it to me to verify.
Thank you so much. Just to add to what we have said, I think in March, we organized a budget analysis meeting, of which we organized it in collaboration with different stakeholders. Maybe one of the stakeholders is the one that reported to SIDA. But SADC-PF, as SADC-PF, we funded the DSS for members of parliament, and other stakeholders also contributed. Thank you.
Yeah, just to address the last question, the question on what we call shadow committees or portfolio committees versus cluster committees. Our system is quite different in Malawi. We have on one end, these portfolio committees which shadow the line ministries, and they meet every quarter. They meet 1 to 2 weeks every quarter, and they're able to summon, for example, the Committee on Health can summon the Ministry of Health to look at their budgets and stuff like that, like their utilization. Now, the cluster committees come into play during the budget session, because what we do during the budget session, when the budget is presented to the House, these committees, which are about 18 committees total, are grouped, paired together. They are paired. So we have a situation where, for example, not for example, Agriculture Committee is paired with the Committee on Natural Resources. And what they do is they look at the budget vote by vote. So they are given a certain amount of votes which relates to their field for them to actually look at each and every vote. And that's where even the program-based budget comes into play, because that's when these committees are able to analyze, scrutinize, and question each and every vote. And after all that, initially, we had a situation where these committees were reporting to the Budget Committee, which is also paired with the Public Accounts Committee, by the way, during the clusters. But they used to report to the Budget Committee, and the onus was on the Budget Committee to take this report to the House. But we've changed all that. We have a situation where we have the Budget Committee reporting on the budget holistically, the outlook, and then these cluster committees report on the votes on the floor. And the line ministries, the ministers responsible for each and every vote is supposed to respond to that. So that's the situation we have in Malawi. It's quite interesting. One, we have this cluster committee system, which I believe not many of us have, but it has actually helped in scrutinizing the budget. We have the program-based budget, and we actually extend an invitation to our brothers from Lesotho to come and actually adopt this program-based budget, move from the activity-based budget. We've migrated from the activity-based budget. It actually helps, and you actually appreciate how it actually makes our work even easier as budget officers. But yes, just to respond to that, thank you.
Thank you so much. In the interest of time, we proceed. We'll call onto the podium Mauritius as we appreciate Malawi with a round of applause. Mr. Marimo.
Thank you, Mr. Jenj. While Mauritius is coming to the podium, I just want to say something. You know, sometimes the context of Parliament makes it very difficult to attribute some of the positive outcomes to Parliament itself, because oftentimes the executive will not acknowledge that we have changed this policy because of the work that Parliament has done. But in some of the instances, we actually know as Parliament that it was because of Parliament that this policy or this legislation was changed. I'll give an example of the re-engineered budget process in Zimbabwe itself. That process was changed at the initiative of Parliament, working with one of our CSOs. I think it was the Southern Africa Parliamentary Support Trust, which resulted in the re-engineering of the budget process to make Parliament more active and to public engagement more comprehensive in the budget process. But the executive will not acknowledge that this was because of Parliament that this happened, which sometimes make it difficult for Parliament to attribute its successes in changing policy or legislation to the work that Parliament has done. But our conundrum now comes in the fact that because we are reporting to donors who are giving us money, we have to demonstrate value for money, that what we are doing has visible impacts and has visible outcomes. So I think that's why Madam was saying, you know, it's not enough to count the bees that visit the flowers, but we have to know the bees that have collected the nectar. So it may not be enough necessarily to say this member made this intervention without then attributing the influence of that intervention to either policy or programmatic changes within your country. but we understand the complexities of what Parliament has to face, because the executive will not acknowledge sometimes that it is Parliament which resulted in these changes to policy and programs.
Thank you, Mr. Marimo. I'm saying thank you. We proceed.
With all protocols observed, good afternoon, SGMM and distinguished colleagues. So my name is Purnika Amjadhan. I'm the researcher and project officer at the Mauritius National Assembly. And over the next few minutes, I will walk you through 3 financial years of SRHR and HIV budget analysis, share our easy gains, present our most urgent concerns, and outline the commitments Mauritius makes going forward. Before I begin, one important transparency statement is that because Mauritius does not maintain a standalone SRHR budget code, some figures in the presentations or researcher analytic estimates derived from budget speech analysis and ministry estimates program lines. While figures are official from the budget estimates, I will say so explicitly. This distinction matters greatly for our SIDA donor reporting, and I will maintain it throughout. Thank you. So from the slide 2, these are the key indicators at a glance, whereby on the top row, we have official figures. The Ministry of Health budget reached MUR 18.5 billion in 2025 to 2026, which is approximately around 390.7 million in USD. So up from 17.2 billion Mauritian rupees in 2024 to 2025. So both are official figures confirmed in the budget estimates documents. In absolute terms, health spending grew by 27.6% over the 3 project years, a genuine real increase above inflation. The HIV/AIDS program 084 received around 320.7 million rupees in 2025 to 2026, which is confirmed again officially from the budget estimates on page 254. And this is the dedicated public health and disease control program that houses the HIV/AIDS unit, harm reduction services, and communicable disease response. At 6.1%, Mauritius health budget as a share of national spending remains well below the African Union Abuja's declaration commitment of 15%. I will explain the structural reasons for this on the next slide, but here the gap is real and must be named. So when we talk about the bottom row, I would like to indicate the alarming figures. For example, we have 549 new cases of HIV cases were recorded in 2024, being the highest number in 14 years. And this is a 43.7% increase from 382 new cases in 2023. And this figure comes from the Ministry of Health HIV/AIDS reports as at December 2024. It's my talking points. Yeah, so coming back to, so this figure comes from the Ministry of Health, which is the HIV/AIDS report as at December 2024, published in May 2025. And it is one of the most important data point in this entire presentation. And we can also see how people who inject with drugs are not a marginal population in this epidemic. They are the primary transmission group, and this has direct budget implications, which I will address on slide 8. Talking about the ARV adherence rate target is 75% for 2025 to 2026, and this also is among those who are already on treatment, distinct from the overall antiretroviral treatment coverage estimate of approximately 89%, which is a researcher figure. Going to this next slide. So here we're talking about the charts. What we can read, the chart shows two stories simultaneously. First is the national total national budget, which nearly doubled from 174.8 billion in 2023-24 Mauritian rupees to 305.4 billion Mauritian rupees in 2025-26, a 70.4 increase. And also, when we're talking about the Ministry of Health budget, which grew from approximately 14.5 billion rupees to 18.5 billion Mauritian rupees, which makes a total of 27.6%. Health grew, but the rest of the budget grew faster. The data table confirms these official figures. 3-year change, national budget plus 74.7%, Ministry of Health plus 27.6%, health percentage share minus 2.2 percentage point. The health share fell even as spending rose. When we're talking about the Abuja gap, Mauritius being at 6.1 in 2025 against the Abuja target of 15%, which makes an 8.9 percentage point gap. Why is it so? We're talking about the structural reason. Social security and payment, pension payment alone accounts for above 70 billion rupees in 2025 and 2026. So that structural constraint limits what flows to health, even with the genuine political will. The health budget did grow in absolute real terms. That matters and should be acknowledged. But the Abuja gap is real, and this presentation calls on Parliament to adopt a phased roadmap to close it. Now, we're talking about the budget 2023-24. Basically, this presentation is about the easy gains that has been reported. And also, I would like to add that in our final document, we have talked about the various questions which we've answered. And I brought my report here so that I will add about the parliamentary engagement at the end. So the budget was named as Today and to Care. I want to be honest about 2023 and 2024. This was a post-pandemic infrastructure push. There was no standalone SRHR budget line and no explicit HIV-specific allocation. The easy gains that I'm presenting are enabling gains, investments that created the platform for SRHR service delivery rather than direct program funding. So when we're talking about easy gain 1, there was a new health infrastructure, which was estimated around 1.7 billion rupees. The new Flak Teaching Hospital, which we now know as the Sir Anirudh Jagannath Hospital, the renal transplant unit, the eye hospital, the 5 new area health centers, all commenced in 2023-2024. This is approximately 1.7 billion rupees from the health infrastructure chapter. This infrastructure expands the platform for maternal health, HIV treatment, SRHR service delivery across all regions of Mauritius. It is an enabling SRHR gain. Now, talking about the easy gain too, we all know right now, and even the past few years, drug has been a parasitic flavor, like we say in Mauritius. And one of the main causes of HIV/AIDS expansion is among the drug users. So the LATSU drug user administrative panel was there. It continued its harm reduction mandate in 2023-2024. I stress this because this is the only identifiable HIV prevention investment in the 2023-2024 budget. The LATSU provided rehabilitation needles and syringe programs and opioid substitution therapy for people who inject drugs, which is, I will say it again, which is Mauritius' primary HIV transmission group. Now, talking about the easy gain free, which is sewerage and sanitation. And this was a 1.1 billion rupees island-wide wash investment, not labeled as SRHR, but directly linked, reducing infectious disease transmission, improving menstrual hygiene management, and lowering waterborne STI risk, particularly for women and adolescent girls in rural communities. Next is about the Easy Gain 4, which is GBV support programs, and they were sustained. The support to women in distress unit, GBV hotline 117, the shelter for women, all receive sustained allocation. GBV is a primary structural driver of women's HIV vulnerability in Mauritius. Sustained funding is a critical HIV prevention investment, even when not coded as such. So we move to budget 2024-2025, which was named as Tomorrow is Ours. 2024-2025 is the most SRHR rich budget of the 3 project years. I will describe 6 confirmed gains. Each provision I name here is confirmed in the budget speech 2024-2025 and is verified in the KPMG Mauritius budget highlights 2024-2025. So when we're talking about that, the first one about easy gain is maternity allowance, which was estimated around 216 million rupees. A brand new maternity mode allowance of 2,000 rupees were per month for 9 months, reaching approximately 12,000 mothers annually were provided. This provision had never existed before in Mauritius public finance. It directly incentivizes antenatal engagement, supporting PMTC, prevention of mother-to-child transmission of HIV, by bringing more pregnant women into the health system for antenatal check, where HIV screening is offered. This is a direct SDG 3.1 investment. Talking about the Easy Gain 2, which is pregnancy medical checkup grant, estimated around 90 million rupees. 3,000 rupees per mother on completion of 6 mandatory antenatal checks, reaching approximately 30,000 mothers. This provision directly incentivizes the completion of the full antenatal protocol, where HIV testing, syphilis screening, and nutritional support are delivered. A dual SRHR and HIV prevention investment. Now, for the Easy Gain Free, there was the mention of the Assisted Reproductive Technology Act. So this was a landmark SRHR which had been mentioned in the budget, and it goes beyond the alignment with the ICPD Program of Action Principles on Reproductive Health and Rights. Talking about Easy Gain 4, there were the free sanitation towels. Grade 6 to grade 13 girls were estimated around 20 million rupees. So free sanitary towels for approximately 90,000 schoolgirls from January 2025 were distributed. And I note that the 20 million rupees is a plausible operational estimate, not an official appropriated line item. The provision itself is confirmed in the budget speech and by the KPMG report. So this addresses the menstrual hygiene management, which evidence show significant impact school attendance and retention among adolescent girls. School dropout is a recognized risk factor for early marriage and HIV vulnerability. So this provision addresses a root cause. Now we move to the Easy Gain 5 for the same year, which was maternity weeks, which was increased from 14 to 16, and paternity leave was increased from 1 week to 4 weeks. So this is a policy milestone. Extended maternity leave support breastfeeding, which is a key PMTCT intervention of HIV positive mothers. Paternity leave extension to 4 weeks promotes shared parenting and reducing the physical burden on mothers in the postnatal period. Both align with the SADC protocol on gender and development and ILO Maternity Protection Convention 183. So we have the GAIN 6, which is again about LATSU harm reduction plus e-health rollout. So this was the LATSU harm reduction panel continued at approximately 350 million rupees, maintaining at the same time, simultaneously, the national e-health system, one patient, one record across all public facilities was extended. So when we're talking about HIV, when we're talking about SRH or even STI records, so confidentiality comes in. And this directly reduces, in a way, stigma, which is one of the biggest barriers to, for instance, HIV diagnosis in Mauritius. Now we move to the last budget, which was the 2025-2026 Easy Gains. And I would like to remind everyone that this government is freshly elected, which has been like 1.5 years. So they are still working and looking at the economic situation, which is prevailing around the world. Like other countries, even Mauritius is facing a very difficult time right now, and the government is trying to give his maximum to be able to look at all, especially for the priority fields one. So when we talk about this budget, it's about rebuilding. That's why the name comes, rebuilding the bridge to the future. And the 2025-26 budget was presented by the Prime Minister, which is Dr. Naveen Chandra Ramgoolam, on the 5th June 2025. And the PM himself personally assumed the finance portfolio. The Alliance du Changement coalition won 60 out of 62 directly elected seats in the 10th November 2024 election, a historic clean sweep. And the budget was anchored on 3 pillars: economy renewal, a new social offer, and fiscal consolidation. I must be transparent here. The budget speech 2025-2026 contains 0 explicit reference to HIV/AIDS, ART, VCT, even PMTC or SRHR. So every gain I name here is identified through analysis of adjacent provision, so not direct program investment. So when we're talking about the first easy gain, which is the HPV vaccination, where girls age between 9 to 14. So This was Mauritius' first dedicated cervical cancer prevention program. The budget estimates confirmed through the program 0801 medical supplies, drugs and equipment, which jumped from 45 million rupees to 101 million rupees, a 124 increase with a new procurement covering the HPV vaccination. HPV, as we all know, is one of the main causes of the 90% of the cervical cancer cases. So vaccination at the age of 9 to 14 provides protection before sexual debut. This is a landmark adolescent SRHR investment. Now, how about the easy gain number 2? So 1,000 student nurses plus 50 midwives plus 50 medical officers for a population of 1.3 were recruited. And this has been confirmed at paragraph 151 of the budget speech. So the official budget estimates confirmed trainee nurses grew from being 283 to 449 in number in this specific year, an increase of 166 new trainee nurses. The midwifery expansion is a direct SRHR gain. WHO data shows a skilled midwife at every birth is the single most effective intervention to reduce maternal mortality. Now, when we're talking about the easy gain free, is about health training budget, which was doubled. And also, this was an opportunity of the Mauritius National Assembly, who is actively pursuing like mandate SRHR counseling module, HIV testing protocols, and gender-sensitive care training for all new health workers for the SADC PF workshop that we usually conduct. And now, when we talk about the easy gain 4, this was the rapid testing kit infrastructure, which had established a rapid test procurement supply chain of around 20 million rupees. So this infrastructure is directly transferable to HIV rapid diagnostic test procurement. And also it enables STI rapid testing at community health centers and HIV self-testing program. There was also the Constitutional Review Commission. So this was a strategic advocacy window for the SADC PF project, with the National Assembly intending to engage the Commission to advocate for more constitutional recognition of the overall framework, legal framework that we have. And when we're talking about the last easy gain is about women entrepreneur loan scheme. So this was the fact that women were given grace period, that is the credit limit was raised from 500 Mauritian rupees to 1.2 million. So, even the UNAIDS evidence confirms that reducing women's economic dependency reduces vulnerability to transactional sex and economic dependency relationship that drive HIV risk. So this is the 3-year SRHR provision comparison. Before discussing these figures, I want to be explicit. Every number on this chart is a researcher analytical estimate. Though Mauritius does not have a standalone SRHR budget program, so these figures are derived from budget speech analysis, ministry estimate program, subline, and unit calculation. They are a planning and advocacy tool for Parliament, so not official appropriated figures. And I will be very brief on that with the amount of time we have. So I'll just mention about how the chart show estimate growth across 6 SRHR subcategories from the year 2023 till 2026. The highest estimated growth is GBV response at a plus 77.1%, reflecting sustained government commitment to GBV services during a period of elevated post-pandemic GBV incidents. And then we move to the next slide. And here it's how the HIV epidemic status and the critical concern is prevailing at the island for the time being. When we're talking about HIV, there seems the line chart tells a story. New cases of HIV in Mauritius were declining till 2020. They then began to raise in 2023, then in 2024. This is not a statistical fluctuation. It is an epidemic statutory change that demands an urgent policy response. I will go directly to the establishment of the NADEC, which is the National Agency for Drug Control. And this has been established with the direct statement from the budget of 2025-2026, and also where the country is facing so much. And one of the questions that normally parliamentarians usually ask, if harm reduction is official strategy, so why do we have pharmaceutical allocation being cut? So these are the accountability questions that we bring to the government. So when we talk about the gaps that exist, and also the top advocacy priority. So here we can see when we're talking about priority one, it's about harm reduction in the NADEC, which is, this is the priority number one. Like I've been saying, and what the statistics are speaking, there's a big problem of drug in Mauritius. So this is something that needs to be urgently approached. And also this year, the NADEC has come with an official master plan alongside with the Prime Minister's office, where there are a group of parliamentarians from all ministries across. They're working closely to tackle this issue, showing the dedication and engagement of the parliamentarian. And also when we talk about priority two, there should be a dedicated SRHR budget program code. Also, it requires no new money. It just simply makes the existing expenditure visible, trackable, and accountable. And talking about the priority free, it's about Abuja. I think everyone, each country, we've been talking about the Abuja Declaration target, which is 15%. So it's like we are saying Mauritius faces a structural fiscal gap with being at 6.1%. And we're not calling for 15% to be reached overnight. We're calling for a formal parliamentary resolution that puts public binding commitment to a phased roadmap on record. Several SADC member parliaments have adopted such roadmaps. It costs nothing. It just creates accountability. And when we're talking about the coverage assessment chart, which is right there, this chart has a visualization of the SRHR budget, which cut across 6 areas, with the smallest segment regarding the HIV program, visibility, standalone SRHR code, and harm reduction. And also, I would like to mention that these are the 3 most critical gaps for SIDA reporting and program accountability. These are the areas where parliamentary action is both needed and most achievable. Moving to the next slide, it's like what was achieved. The left column lists genuine achievement. I just want to highlight 3 of them, which demonstrate direct parliamentary impact. First is about the HPV vaccination program for girls aged between 9 to 14. I would like to mention here, in Mauritius, we don't have specific committees. We have sessional committees. And the committees, which I've mentioned in the report as well, we have the Parliamentary Gender Caucus, which we work closely, especially we are in their meetings and they form part of our technical group as well, because we have the SADC PF MPs who are both in Parliamentary Gender Caucus, even in the Public Accounts Committee. So we're working closely with those committees, and they usually, I personally have attended their meetings, and the amount of engagement that we have from the newly, freshly elected members is commendable when we talk. And especially right now, we are working on the domestic abuse bill. It's going to be enacted soon. It's at the legal Ministry of Legal Affairs, so it's there, and also at the DPP office. So they are working on that, and these are one of those key achievement that is being heard there in Mauritius. So from like a parliamentary gender committee recommendation translating into new SRHR commodity procurement budget line. So this is what parliamentary SRHR governance looks like in practice. And also talking, there was about the hands-on section. So, for example, there was a question, a parliamentary question in December 2024 on stock out of the medical supply. So this directly linked to confirm, because when we're talking about medical supply, we're talking about antiretroviral treatments, which are going, for example, here we're talking about Rodrigues Island, which is form parts of the Mauritius constituency. So there was a question, and also when we see the budget allocated for Rodrigues Island, there is an increase, and that shows how the parliament oversight function is producing measurable health equity outcome for an outer island population, and that is accountability that works. And also, we're talking for the Ministry of Health and Wellness, the SRHR metrics are now embedded as official KPIs within its program-based budget. So when we're talking about the 2025-26 budget estimates, they include the UHC Service Coverage Index, the HIV positivity rate targets, patient satisfaction, and IRH capacity index. Parliament called for it. It happened. We demonstrate this shows those results. Sorry. And also, when we're talking about what needs urgent action, the middle column is not a failure statement. It's an accountability statement. When we're talking about, for instance, new HIV cases in 2024, with 549 in numbers, there are no standalone SRHR budget codes. And also, there's no, for example, no GBV allocation visible in that budget speech. No key population services for MSM or PWID. So an IBBS survey overdue since 2024. And these are those accountability gaps that we are trying to bring to regional peer review today. Now, talking about how Mauritius has done so far, to be honest, Mauritius has done genuine progress. We've seen the Ministry of Health budget growing in real terms, new SRHR provision being introduced, Parliament's oversight mechanism producing measurable results. But to be very honest, we're not here to celebrate. The picture is not as rosy as it is, like my colleagues rightly said. So we are here to be accountable to SIDA. We are here to learn from our SADC peers, and also to commit to the work what is being remained. The work has been done. It's not enough. We need to do more. And also, for example, when I'm talking like 549 new cases of HIV, it's not just a statistic. These are 549 people. And it kinds of shows how, as an administrative and a public health, I won't say failure, but maybe a weakness. And why weakness? It's like trying to see the positivity in that so as to tackle the problem. So these things cost life unless Parliament acts. And also the absence of an SRHR budget code is not a bureaucratic oversight. It is, again, the words come here again, it's an accountability gap that undermines everything we are reporting here today. For example, the Mauritius National Assembly commits to institutionalizing GRB tools, establishing a dedicated SRHR budget code. And now the proof working with SADC Parliamentary Forum and SIDA, so each rupee that is being invested in terms of health serves the women, the adolescent, the key population of Mauritius, with special attention to those who are the most vulnerable to HIV and SRHR related harm. So this picture is about the newly built hospital, and it was inaugurated on the 21st August 2024, and it's the largest public health hospital in the Indian Ocean region. And why I've included this photograph, it's like, because this hospital as a whole, it's a physical embodiment of what budget investment in health infrastructure looks like. The 4.3 billion rupees in total project costs across the phases 1 and 2 represent the largest single health capital investment in Mauritius' independent history. It was co-funded by 3 international partners: the Arab Bank for Economic Development in Africa, the Kuwait Fund for Arab Economic Development, and the Saudi Fund for Development, which provided a 50 million USD soft loan. So this hospital has a dedicated neonatal intensive care unit, a nursery, a special baby care unit directly supporting maternal mortality reduction and SDG 3.1. And also it has mammography for breast cancer screening, fluoroscopy for reproductive health procedure. It has 35 dialysis machines enabling 100 treatments per day, chronic care capacity that serves patients with HIV-related and NCD-related renal complication, which is a big issue as well in the country. So for me, this is what parliamentary budget advocacy looks like when it works. So the 1.7 billion health infrastructure provision in the 2023-2024 budget is a hospital that was opened in August 2024, serving hundreds of thousands of Mauritians. This is the return on the investment we have been tracking. And now just to add on about the parliamentary for example, influence on SRHR financing, which is in the report. So I'll just go briefly. Some of the concrete parliamentary intervention during the years 2023 to 2026. During the 2024-2025 budget cycle, the maternal and reproductive health parliamentary stakeholder discussions were increased. So they highlighted the strengthening of maternal reproductive health investment. The 2024-25 budget subsequently introduced supported the maternal health, including the maternity allowance and the pregnancy health checkup. And also when we're talking about whether, how the parliamentary engage through their influence, it's about formulation. When we're talking about formulation, it's parliamentary commitment, stakeholder consultations, and next is about approval. There are debates that goes on. Debates on, for example, recently we had the appropriation bill, proposed amendment to health and gender budget lines, parliamentary questions to ministries of health and gender equality on SRHO. Then the third point is about execution. How the parliamentary oversight activities, including committee engagement with health and social institutions, supported monitoring of program implementation challenges affecting healthcare and protection. Here, I would like to have a special mention to our SADC PF peer countries who are doing wonderful with all the activities that all the countries been doing. So that's where it contributes to how we are influencing the parliamentarians, and thus eventually they are resulting into those actions that are being taken. And the fourth is about audit, where we talk about the Public Audit Committee who reviews, and also the auditor tracks about how health programming is being spent, and it's basically the parliamentary tracker for Auditor General recommendation on health and social protection. Thank you, everyone.
Now I open the floor for questions, contributions, but I'll start obviously with Raj, your immediate reaction, if you have any.
Thank you, Asha. Okay, let me talk about two issues that the researcher pointed out, but I will put some more emphasis on it. Two challenges that she did mention. The first is drug. We should not undermine the effect of drugs in Mauritius. It's very, very high. When she was talking about the 549 new cases, she was alarmed because it's from 300, it went to 549. But on the region, this is nothing, the 400, when we are talking of 5,000 maybe new cases per year in some countries, or even more. But what is interesting, or what should we concentrate on, is what causes those HIV. It is drugs. It is use of needle that they exchange between those drug addicts. So we have a problem of drugs, and they share the needle amongst themselves, spreading the HIV. So there is one issue that we need all to think. Should the state provide needle to drug addict? It's encouraging drug, but reducing HIV. Already an NGO is already doing it. It shares needle with drug addict. So it's a difficult dilemma, but it's there. So that is one. The second issue, I think she never mentioned, she didn't mention about family planning, but she mentioned about the pregnancy care allowance or something. So this also is good to share among colleagues, that Mauritius is facing an acute decreasing population over 10 years. The population each year is going down. If you go to Mauritius, in the supermarket, bakeries, shops, you find foreigners working, hardly a Mauritian working on the castile. So it's mostly Madagascar, Indian, or from Bangladesh, or Nepal. So that's the acute problem. And to solve it is very difficult because it's an issue of culture and many other issues. And this is why she mentioned pregnancy care allowance. So a woman who gets pregnant right from month 1, she gets around 3,000 rupees, which is around 1,000 rand. Just to encourage a bit. In terms of birth rate, I will put figures because sometimes it's on 1,000 and it becomes complicated to compare. Some 30, 40 years, each year there was around 25,000 births. This was in the 70s, 80s, 25,000. Normally today it should have been 40 or 50,000. But right now, each year is around 10 to 11,000 only. It decreased more than half. And in terms of health statistic, what we call, to maintain a population, a woman should have at least 2.1 child per woman. Normally, they use a decimal also. In Mauritius, I think it's 1.3 or 1.4. So they are below maintenance level, per population. And if you read reports from World Bank, IMF, and others, they say if the trends continue and no remedial action is taken, by 2050, the population may drop less than 1 million, and it may not be economically a feasible, viable country, because you will get shortage of workers, and also the aging issue. You will have fewer young people working to subsidize the elder people. So these are two challenges, and it's very, very acute. It's a bit different from the mainland here, but we can't undermine these two. Thank you.
Thank you, Mr. Raj. I would like to point out something. There is a very paradigm shift that is going on. And also talking about SRHR, now when we're talking about priorities for the SRHR itself in Mauritius, now it's shifting to the aging population. Now we have to shift to see what are the SRHR needs of the aging population. And to be honest, it is a stigma as well as, I would say, a generational gap as well, because it is, we all know for youngsters to even speak about it, we are still evolving in that aspect. But for the elder people, it's even more difficult. And to approach them, maybe the kind of terminology that we're going to use, that we're going to do, for example, those sessions with them, a workshop with them, needs to be reviewed, needs to be toned down. And also, when we're talking about SRHR problem, their problem comes with multi-dimensional aspect. With what I mean, we're not just talking about women's health, we're talking about the men's health. We're talking both, because they are dealing not just the aspect of SRHR, it's SRHR and mental awareness also. Thank you.
Thank you so much. I open the floor. We have South Africa, Malawi, Namibia over there, Sadaq here, sorry. Then Lesotho.
Thank you. That was a very interesting and insightful presentation. A lot of detail. I think we take for granted the amount of detail it takes to pull this together. I think for me, I want to almost piggyback on Raj to say the needle program was really jumped out to me, because in Greece in 2010, 2011, when they were implementing austerity policies, what actually happened is that they cut their needle exchange program for drug users, right? And what happened is that new HIV infections leapt by 52%. So what at least I will always ask, is at what cost? So when we talk about our budgets and we think about what are the quote unquote trade-offs, because that's the language we use, right? With this year, we don't have money for X, but to think about health in particular as the long-term cost. So you saved 1 million this year because you cut the needle exchange program, but you're going to spend way more in the long run to treat those people who are now HIV positive. So the cost today is not the cost tomorrow, right? So I think that to me raised this thing that I think all of us maybe haven't really spoken enough about how Parliament holds the executive to a longer term plan, especially with SRHR, to say, how do we think about tomorrow? Today we're talking about budgets, what are we spending today? But I think we really need to think more and talk more about, the long-term costs of, and I think we know them in our heads, but I think, there's room there to talk about how Parliament holds the executive to account, not just on a budgeting exercise, but to think long-term. And I know many countries here will say we've got this deficit and so forth, but the question is, which I would rather South Africa not have a budget surplus and spend that surplus on SRHR or whatever program, than have a budget surplus when we're going to have an accumulation of long-term costs.
Thank you for the wonderful presentation, my sister. Quite detailed. Mine is not necessarily a question to you, but an observation to our resource persons and indeed to everyone in this room. I've noticed some sort of inconsistency. Ministry of Health versus the health sector. These are two distinct entities, I'll call them, quote unquote. But I've noticed like some presenters are referring to the Ministry of health and actually like taking that against the Abuja target. So maybe this is just an observation and we need to come up like maybe to have that uniformity and to clearly distinguish these two things because they are quite different and we may end up interpreting the target, the Abuja declaration, because we're mixing these two up. Thank you.
Thank you very much, Chair. First of all, I'd like to applaud Mauritius for a very detailed presentation. I had two questions, but one has already been answered. The first was to do with the source of the underlying data that is being presented. And she mentioned that it's the budget statements. That is fine. She mentioned something to do with the Office of the Auditor General providing audits and oversight over resources that are being employed under the SRHR initiatives. I'm an internal auditor currently with the SRHR, as I mentioned earlier. From my experience, the Auditor General's office faces a lot of challenges. One of the biggest ones is delayed audits. In government, you find we're in 2026, the office is auditing 5 years back data. Now, I just wanted to find out from your experience in Mauritius and just to share how effective is the Auditor General's office in providing assurance over the utilization of SRHR resources? Thank you very much, Chair. Thank you, Program Director. Mauritius, your presentation is very informing, but I have a question. You indicated new HIV infections in one particular year, rising to 449. And then at the same time, the country has this initiative to give allowance to people who fall pregnant. What is the logic behind it? Don't you think that initiative is the cause of the rise? Yeah, because I'm trying to link the two initiatives. If it raises the alarm for you, the 449, then at the same time, we somehow encourage unprotected sex. Yeah.
Okay, thank you very much, Mauritius. Indeed, I join everybody else in applauding your presentation. Mine is just to basically indicate to everybody else, including you, that, you know, some of these questions should really trigger an in-depth analysis, which is already there. Let's start at the title of the project. The title of the project is SRHR HIV/AIDS Governance. There's a component of rights. I'm encouraging all of us to really look at the rights component of what they're talking about and give an analysis, because you do that anyway. I mean, for members of parliament to feel robust enough to engage, you weaponize the whole debate or any question with that particular angle to say, for our people, this is what is going to work. But we also are aware that the rights component in the realm of SRHR brings about many other issues. The legal environment, what rights are being violated, which rights are being upheld. In that area, what could be reversing the gains or could reverse the gains? Particularly when we look at linkages. I know all of you said, I don't know, somebody said something about now we have friendly. Yeah. The issue of rights should allow us to really look at the services that are being provided. All of you spoke about out of pocket, the quality of service. Are they affordable? Are they, some of you talked about stockouts. Are they accessible? I think it's quite important. I also like the fact that Mauritius was not just floating. They really tried to look at the whole cycle of SRHR. Infertility, that issue came up. They talked about fertility. They talked about protections, at least of drug injecting populations. And I know in all our countries, the issues of rights under SRHR, where are your sex workers? Where are your vulnerable groups in this? Where are your migrants? Where are your men who have sex with men? Where are your LGBTQI? If you don't know where they are, analysis. If they don't exist in your country, analysis. If the law does not even allow reporting or recognition of such groups, you are dealing with an underground epidemic. Perhaps you need to know why are you having the rise. I appreciated Mauritius and the others who mentioned, because at the end of the day, what are we saying about HIV/AIDS? That is sitting there, that you're providing antiretrovirals, and why are you doing that? Is there growth? Is there prevention? So please, let's just not throw the numbers in there to look at what is happening. Safe abortion is another issue. Safe and healthy relationships. When you go to the definition of sexual reproductive health and rights, what is your tempo? What is your observation in terms of the numbers that you are seeing? Who's been missed? Because the project talks about universal health coverage. So please go back, look at those indicators. You don't have to cover all of them, but you must be able to say, in our context, this is what we see and this is what we need to prevent. I also want to say, also, if you are in doubt, look at UHC outcomes, universal health coverage out. It will help you. Look at your data afresh and you'll be able to, apologies, you'll be able to deepen your analysis. I also like what Malawi indicated. Differentiate health sector and Ministry of Health. Some of these things may not be readily, things that we looked at thoroughly as we're preparing. As we indicated, this is the beginning of a long journey. We would like to publish each country's report after it having been peer-reviewed, after it having gone through further interrogation, and would like to publish and have you listed as people who have contributed to this outcome. It always breaks my heart. The reason why I mentioned the earlier article on Malawi, I called Malawi, they're like, no, this is our meeting, SG. I'm like, yeah, but you didn't write about it. Some of us are in this job because we believe in the value of parliaments. I also don't believe that there's any parliament whose life and whose current job can be thrown into the dustbin of life. And if you work for parliament and you still cannot document that and really show the value and the investment case to parliaments, you should go and work for the executive. So this is an exercise where we're trying to say, we have budget offices in some of these parliaments. We have you who are technical people, we have other colleagues. If you were asked, if you are told today that we're shutting down parliaments, after all, we can do everything we want with ministries. We can only have a minister, all they do is ask questions that don't go anywhere. All they do this, which, what would you be your attitude in writing these particular submissions? So I just want you to have this at the back of your mind as a long-term investment case for parliaments. And go further. Don't allow yourself to be seen as having plagiarized what the minister ought to be talking about per se. Of course, you can cite, you can broaden, but locate this in parliamentary democracy. located in citizen participation, located in the concerns that anybody else who is hired to speak for the people ought to. Anybody else who's a lawmaker ought to be concerned about the issues of rights, the legal policy environment, among others. So thank you very much. And I just want you to say, it's very important that I like the fact that you brought in the infrastructure, disease management, because that is part of the health sector response and what we'd like to talk about. So let's think about those things, colleagues, because you'll find that those are the low-hanging fruits that you can really attribute to Parliament, and then speak to why parliaments really wanted services to go in that particular way. Would really like to publish this, and we also request you to assist us. That is why we have colleagues from the budget office facilitating. I call upon you, if you have colleagues in budget office that we're not aware of, please let's link. Let's also link with the local university so that ultimately this is peer reviewed. This is something that can go beyond us and can really show the level of effort that you have all put in. Thank you, everybody, today, and thank you, Mauritius.
Thank you, SG ma'am.
I think SG has said it all. She has actually wrapped up in terms of the responses. She was meant to respond, isn't it? But I think SG did on her behalf. You did, SG, you did.
I didn't mean to usurp, but I guess give her an opportunity, otherwise I'll be misunderstood.
I discussed with her already. We said in the interest of time, we shall proceed. So another big round of applause for Mauritius. Thank you so much. All right. So
let me also say, where is the lady from South Africa?
She went out.
She must continue being the devil's advocate, because she's really taking us to the root cause. Don't just put numbers, think, what does it mean? You know, now this is where you're going to spin for Parliament's sake, and for the people's sake, and for governance sake, so that at the end of the day, this institution is seen to be delivering as expected. We want, the Afrobarometer says people now go to traditional leaders when they were asked whose confidence they would, you know, who they have confidence in. What number were we, Kurash? I don't know, Parliament was at the bottom. They believed in religious leaders, traditional leaders, among others. So redeem us, colleagues. That is your job. And we are looking forward to that from your end. Thank you.
Thank you so much, SG. So it's exactly 5:08. We shall break a little bit, then we come back again and continue. Are you good with that? No, then. Are you good with it? Huh? We break for 30 minutes for tea, then we come back and continue with the presentations. I'm a democratic masters of ceremony, and it appears all right, ladies and gentlemen, I think we call it a day. It's been a great day. There is what we call the law of diminishing returns. So we don't want to fall into that pit. So Mozambique, Namibia, South Africa, Zambia, and Zimbabwe, please go and refine your presentations together with Botswana. Go and refine your presentations so that you make your presentations first thing in the morning tomorrow. Then you'll be guided in terms of how we're going to restructure the program. But having said that, thank you so much. You did well. You deserve a big round of applause. SG, I don't know if you have anything to say.
I'm all smiles.
SG is all smiles, so it means we did a wonderful job. Thank you so much, colleagues. We meet tomorrow.